Good morning, ladies and gentlemen, and welcome to the latest public conference of the Science Business Network. Thank you very much for those of you who've traveled to be here with us in Brussels and for those of you joining us online. My name is Simon Pickard. I'm the director of the Science Business Network, and I'm delighted that today's event is building on a legacy of a number of high-level discussions that we've been convening over the years, with the mission of bringing together the worlds of research, policy, and industry for forward-looking discussions about key areas of science and tech policy and what that will mean for the world of research and innovation. So first and foremost, a big thanks to our two supporters for today's event, Novartis and Smart Change, without whom we wouldn't have been able to convene today's important set of discussions. For those of you who are perhaps less familiar, Science Business itself is Europe's leading media company focused on research and innovation policy. And our network is what makes us unique in that we have a club of 85 leading organizations, either paying for, programming, or performing research and innovation across Europe and increasingly at an international level. So, our focus today is on health and life sciences. And as you know, hugely important for many areas of European competitiveness, security, preparedness, innovation. I think we all know the buzzwords. And of course, this is being reflected in a significant amount of legislative activity here in Brussels and at member state level. We're still in the process of finalizing the general pharmaceutical legislation revision. We have critical medicines, we have the Biotech Act, which will be out next year, all of which are key attempts from the policy world to try and unify and streamline and turbocharge the performance of health and life science sectors and the research that underpins it here in Europe. So today's entry point is really the Choose Europe for Life Sciences strategy. We're going to touch on some of those other areas and pieces of legislation. But as many of you will know, the Commission launched the Life Science Strategy earlier this year with a view to removing some of the barriers, the complexities, and some of the fragmentation, shall we say, within Europe's R&I ecosystem when it comes to health and life sciences. And so we're going to be looking at various aspects of how the strategy and some of these other areas of legislation are going to have an impact on the life sciences R&I community in Europe. We're going to have a first opening panel that looks at the importance of clinical trials reform and clinical research. Second, after the coffee break, we'll move on to the R&I value chain and how to strengthen Europe's ecosystem. And then we'll have a third set of discussions around how to harness the potential of AI in life sciences. So, to get things started, I'm delighted to invite Maria Pilar Aguar Fernandez, the newly appointed Director of People, Health and Society at DG Research and Innovation at the Commission, to come and give us a first sort of state of play on the life sciences strategy, where we are in terms of implementation, what comes next, and then we'll broaden it out to the panel discussions. So please join me in welcoming Pilar to the stage.
Thank you.
Thank you, Pilar.
Thank
so
you.
You can stand or sit,
Well,
maybe seating is easier, a little more comfortable.
They always tell you that standing is better for speeches. But
Well,
I'm fine. I'm
Very
fine with
good,
that.
but thank you for being with us.
Thank you, Simon. Thank
So
you.
kick us off.
Okay.
Where are we with the life science strategy?
First, let me thank you for giving me the opportunity to share a few of the hints, because there's many, many things, as you have mentioned, happening. But I will just go through a few of the details. Obviously, 10 minutes is very little time. So I will focus on some of the areas or some of the activities or initiatives that might be of more interest for the audience today. But let me start by something pretty obvious. 5 years ago, COVID-19 crisis was a wake-up call, not only for Europe, but for the entire world. But for us in Europe, was a really serious wake-up call to realize that we had to strengthen our crisis preparedness, to strengthen our autonomy and the resilience of our society. So that was 5 years ago, an eternity. But today, you all witness how rapidly the global scene is changing. And again, this is another call for strengthening our competitiveness and the single market. And I think that life science just offers many opportunities to work in that direction. Progress in life science is already transforming our key economic sectors, many of them. The vast majority of you might be interested on the health part, but it's true that it's also transforming the agricultural, fishery, forestry, biomanufacturing, and there are many opportunities also for the environment. So it has an important impact, life sciences, in the economy, the global economy, not only for R&D business, but beyond that, the contribution to the GDP, and even beyond that. Let's face it, there are a number of employment, an important number of employments that are related to life science. But we want more, we need more, and we want to work for more. It was always, life science was always, or traditionally, a very strong field for us in Europe, and that we know. But the trends are changing, and we see that in areas, in certain areas, we're losing ground to international competitors. It's always mentioned USA, but I think that in specific fields, China is a very, very strong competitor for us, bringing life science innovations to the market. So this is why we developed the strategy. But let me reflect on one thing. What does it mean to be competitive? Some people have a very narrow aspiration or an understanding of what competitiveness is, but this is certainly not us. This is not only about having vibrant industrial sectors that thrive and can compete globally. That's fine, and that is a very good aspiration, but we have to go there. We have to have the aspiration of cultivating a really vibrant life science research and innovation ecosystem where we create opportunities, not only because we develop products or we have major discoveries and breakthroughs, but we also provide opportunities for the new to come skilled generations, European researchers, and beyond Europe as well. This is also related to the Choose Europe thing. It's about developing safe and sustainable products that are going to have a positive impact on patients, on citizens, on ecosystems, that need desperately these advances. And in a way, what I want to express is that competitiveness is an enhanced well-being for all Europe, for our environment, for a more competitive workforce, for healthcare systems that are maybe saturated today. So we want to understand that in a really broad sense. And we want to find opportunities and lift hurdles on the development, deployment, but also the uptake of these innovations. This is what we're trying to do, and this is what the strategy is about, to facilitate the journey around, or across the whole life science innovation chain. And this is why we have proposed actions in 3 different phases, if I can call it like this. So first, an optimal RNA ecosystem where we facilitate access to the existing resources. And by resources, I mean a lot of things. I mean data, I mean tools, I mean expertise, I mean infrastructures. All of the things that, together with establishing collaborations, are going to help us advancing. So that's the first part, the science, really pushing the science part. Then ensuring the swift access to market. We know that in certain domains, this is an issue. Let's not be naive and let's close eyes to reality. So this is why part of the European Life Science Strategy also proposes the examination of a number of regulatory processes and strategies to really help these innovative products to reach easier or faster the market. And finally, let's also not forget the end users, because in times where, I'm sad to say, where we see, distrust in science, we see the activism movements. I mean, we need to engage and dialogue with citizens and stakeholders to make sure that the innovations that are put at their disposal are really benefiting them. We have a number of actions in the strategy, And I'm not going to enumerate everything that we're doing in these 27 actions, but let me point out a few major flagships in which we're already working, which are, the areas where we thought that there was important work to be done as soon as possible. You've already mentioned the European Biotech Act, which I know it's of interest of a number of people in the audience, that will aim at make the EU regulatory landscape more conducive to innovation. It's a big endeavor, we know that, and this is where we are really already working on the matter. And I will say it again at the end, this is not about us. It's not about the Commission working in this little tiny corner, in obscure places and desks doing things in isolation. It's not about that. And to show why I say that is because very often, in the vast majority of our initiatives, we call for public consultations. And actually, as we speak, there's a public consultation open on the Biotech Act. It will be open until the 10th of November. I don't want to invite you to give input. I think it's your duty to give input, because each of you have a view, each of you has an idea, each of you may face different difficulties or may have found solutions. And this is why I say it's your duty, more than an invitation, to help us making the best of it. So please do share your ideas, your comments in this open consultation that is open until the 10th of November. So that is one of the areas, about research, about regulation, and so on. But also we have to acknowledge that access to funding is not necessarily very easy for some of the companies. Bigger companies might have other issues, but the smaller companies, and I'm not only referring to SMEs, but as well, scale-up companies, they might not find easily access to funding and investment. And this is why we do have the idea of pushing and helping startups pairing, so to speak, of finding investors. And we are creating what is called the Life Science Investors and Corporate Interface. So practically speaking, what we aim at is to have this interface, which will help putting in contact trusted investors around. The European Research Innovation Council has this network of trusted investors, and we want to actually bring them closer and put them in contact with life science startups that can then showcase their potential technologies or solution, and then will be hopefully picked up by this network. One of the other things, and this is internal cuisine, one of the things that we are doing also is creating this coordination group in the Commission, because life science, as I say, span across a number of Commission services. We want to work together to have a coherent approach, have really make the most of it, synergize, and create it really an impactful work. So this is why we are working in this coordination, and we expect also to have, if I can say that, replicated this effort outside. Because let me say one very clear thing. This is not about the Commission saying, okay, I'm going to work, we roll up our sleeves, I produce this, I produce that, I put this funding. No. That wouldn't work. We never work like this, and it's not going to work in this way. We want, as I have mentioned before, each of you, and I am calling here citizens organization, patients organization, industry association, academia, everyone. We absolutely, I am hoping that I have regulators, member states. I'm hoping not to leave anyone uncited, but if I have not cited anybody, please believe that I am citing you, because each of you have a role to play on this. We are not working in isolation. We will never work in isolation, and actually, this is, if we were to work in isolation, this would be a failure. So this is not what we want to do. it's quite encouraging seeing that already the member states have given very good signals. You may have heard that under the Danish presidency, a few weeks ago, there have been council conclusions really aligning, encouraging the Commission to do this work, and really flagging the importance and the also the readiness of member states to work together with us. So this is today. Maybe somebody wants to ask, and I'm assuming that I will be asked questions about tomorrow, because our way of working, as you all know, is these multi-annual financial frameworks. The discussions, the proposal for the next one has been presented already. Many of you that within that proposal that presents a number of novelties, we still have a standing alone, let me use Commission jargon, FP10, which is Framework Programs for Research and Innovation. The proposal is pretty ambitious. It is, practically speaking, doubling the current funding. And this is because, of course, as I have mentioned, and it's not only Mario Draghi saying it, and it's not only Enrico Letta saying it, in their report, we are intimately convinced that research and innovation must be central to this competitiveness, and again, competitiveness in the broader sense. So the proposal is there. It's pretty bold, quite ambitious. There are also some novelties. You might have heard about the European Competitiveness Fund, so there will be opportunities for different funds to contribute or to have synergies or to maximize that. But again, we shall see. And again, a plea for all of you. This is the Commission proposal. And those of you that have been living through these cycles before know that there is an important role to play at the end of the day by both the Parliament and the Council. And the ministers around the table are going to decide on what is the final shape and size of this proposal. So it's also an invitation, if I may as well, a duty for all of you. If you're convinced that science and innovation are central to competitiveness as we do, please go out and talk to your stakeholders, talk to your ministries, talk to your governments, talk to your parliaments, and make sure that they also understand that and they support this ambitious proposal by the Commission. And I'm not only referring to ministries of research, which probably are convinced, but also other actors, ministries of finances, national parliaments, even regional parliaments. So please help us helping you. That's a second plea. But again, we will see more out of this in a few months, and we see how this will develop. A final plea, if I may?
Of course.
So let me say something. I've been working in the area for long, and I have realized that research doesn't happen in isolation. You may be in a moment working alone, but research is a continuum. It's also a journey. And I would like you, and I'm talking now to the researchers or the ones really closer to this development, I would really want to ask you to identify very early the next steps of your work. And I'm not saying you have to leave your work and continue, but you may want to, reach out to the next step in the chain that I was mentioning before, and make sure that your innovations, that your discoveries, that your breakthroughs are carried over, and then finally they reach our citizens and our society. Because it's only like this, focusing on this work and this translation into, real benefits for everyone, that we will achieve competitiveness. And for this, we need to work all of us together. That's all. Hi, Mom. Thank you.
Pilar, thank you very much. That's a great way to sort of set the scene. And you've teed us up quite nicely, because this question of harnessing the power of Europe's legacy and today still acknowledged excellence in fundamental research across all kinds of health life science sectors, and getting that accelerated through the value chain towards market therapeutic solutions for patients, it's one of the critical challenges of our day. So, within that context, we're now going to talk about clinical trials and clinical research as what some call the beating heart of the RNI ecosystem in life sciences. And how can we address some of these regulatory issues, the regulatory innovations that would allow innovation to flourish in Europe? And to do that, I'm going to invite a couple of guests in the room and another online to come and join us for our first panel discussion. So allow me first to introduce Clara Hellner, who's Presidential Advisor for Life Sciences at Karolinska Institutet in Stockholm. Clara, welcome to you. Second, Martin O'Kane, who's the Head of Regulatory Liaison, EU Policy, and other regulatory matters at Novartis, based in London. Martin, thank you very much for joining us. And online, we have Marianne Pilgaard, who's the Chief Executive Officer of Trial Nation in Denmark, a public-private partnership, which is essentially trying to innovate and facilitate an accelerated performance and impact in the Danish context around clinical trials and clinical research. And in a slight change in plan, Tomislav Sokol from the European Parliament will be joining us a little later, as he's been called to an emergency vote in the Internal Market Committee. So, I think many of us who live here in Brussels recognize that the Parliament has its own way of working, but he will be with us a little later. So, let's get the conversation going. Right? Clinical trials and clinical research, very much central to this future competitiveness, security, innovation, and resilience agenda. We've seen over the last few years that Europe's share in the global clinical trial marketplace has dwindled, and the challenge is to reverse that trend. And the life science strategy is a clear part of the European institutions' attempts to do that. The Biotech Act will hopefully complement and strengthen that. But first, I'm going to ask Clara, Martin, and Marianne, how confident are you that Europe's on the right track, particularly in terms of ensuring the long-term competitiveness and market leadership of its health and life science sectors? Clara, perhaps you give us the first couple of thoughts on that.
Yeah, thank you very much. I think one important piece of the puzzle is in place in the fact that we are all aware, we share the problem picture. And that's a very important first step, because if you don't agree on what we need to solve, nothing will happen. So that's very good. And I think the life science strategy actually identifies a lot of practically the same areas that we have talked about in Stockholm for many, many years. Of course, we have a regional life science strategy that very much aligns with the European one. So that's good so far. Having said that, I know also from having done a lot of strategic work that it doesn't happen on this level. It needs to happen somewhere else. And when it comes to clinical trials, they need to happen in healthcare, and healthcare is very pressured. So how do we solve that? So I think if we compare it to the European health data space, I think one advantage with that has been that it has raised the awareness regionally and locally, in my context, the need for using health data, not only for primary use, but also for secondary use. So it has put a lot of pressure on the national level, and then the national level puts pressure on the regional level. And then for all of us in the research community, we can say, hey, EU is talking about this as well. The government is talking about this as well. Something needs to happen. With clinical trials, I don't see that. I don't see the push. So in Sweden, for example, there's a lot of action towards this direction, but it's a bit slower, and it doesn't have the clear framework that the health data issue has. So I think that would be good if you have strong signals, that this is equally as important as health data issues. And I think also what could be good is if there were some kind of incentive or stimulation that can send strong signals that if you do this, you will have something in return. It doesn't have to be much, but it's a signal. So that's one thing with the clinical trials. And then I think another issue that we don't talk as much about on this level, but more on the regional level where I am, is that what is our advantage within the framework of clinical trials? What type of clinical trials can we do in Europe that you can't do elsewhere? And we have the advantage of having big public-supported healthcare systems with lots of population-based data very much attractive. The US does not have that. And they cannot follow up patients for long periods, which we can do, at least in the Scandinavian countries where we have digital data since decades back. And we underuse this opportunity, and one reason why we use it is that we don't get access to the health data, but that's another issue. But we have the opportunity, it's there. And I think also clinical trials, I talked to someone here in the public who will come on stage later say we won't need them anymore when we have AI, and that's another issue, but still we need them for a while. And I think the way we do clinical trials is not very sophisticated. We stratify patient groups based on sex and gender and age and a number of inclusion criteria, but we need to stratify them on type of tumor or type of, I don't know, whatever, and life situation and whatever, behavioral issues. And we could do that much better if we have all these data, the multimodal approach. And then we can also stratify them on the multimodal approach, but we can also follow them up on the same level with the RWD follow-ups for long-term, short-term, and long-terms. And this is a unique thing that we can do in many countries in Europe, and I think that we should really go in that direction. And then, of course, clinical trials is data collection and data sharing. So we need to facilitate data collection, data sharing.
Perfect. Thank you, Clara. Now, Martin, let me turn to you.
Thanks, Simon.
From the industry perspective, how do you feel?
Yeah, from an industry perspective and a regulatory perspective, in terms of the confidence, I'm confident that the message has been heard. I think Commissioner making the right noises. It's great to see that there is a political will that something needs to be done and something needs to be done urgently about the clinical trials ecosystem in the EU. It's also encouraging that on a kind of regulatory basis, there are initiatives that have been stood up, like the Accelerating Clinical Trials in the EU, ACT-EU initiative, which brings together health authorities and ethics and patient groups, sponsors both industry and academia. So that common purpose is there, and I think using that umbrella in Europe is really important, and the initiatives under the ACT-EU umbrella, I think, are starting to show some positive aspects. But, and there's always a but, but I think these initiatives are tackling today's urgent and immediate problems, and what we need to see is real structural and transformative change for the future. You talk about kind of confidence in the long-term competitiveness, and under that aspect, I would say the Biotech Act provides an opportunity. And hopefully we'll get a chance to talk a little bit more about the Biotech Act in a minute. But I think really moving towards an outlook where we are one region with one ecosystem. So reducing the complexity in the system, the fragmentation in the system, the duplication in the system from a regulatory perspective is going to be really important. I'm cautiously optimistic that we'll get there. I think one of the issues with the clinical trials regulation is that the regulation in itself seems to be a great idea. If you look at the overarching objectives, really good idea. But the implementation and the interpretation of that has meant that we see the fragmentation that we see today. So really addressing that issue fundamentally is going to be important for competitiveness in the future. And it's important, right? It's important not just for competitiveness, but for patients. So having a thriving ecosystem in the EU is really important for patient access and pulling research and innovation from trials, which is the unit of development, all the way through to registration. And I completely agree with Maria that it's a collective effort. We really owe it to our patients in Europe that we're doing this together for the competitiveness in the long term.
Fantastic. Thank you, Martin. Now, Marianne, let's turn to you. Welcome.
Yes.
Hope all is well in
Thank
Copenhagen.
You.
What are your first thoughts
absolutely.
on the direction of travel?
I think that I agree with all that has been said, that there is an understanding that we do need to act now. And I do see that there is an alignment across EU 27 that actually we do need to take action now. I can be worried a bit about the speed and as Martin also alluded to the implementation. We have a concept which we call operational harmonization of implementation. And I think that we can definitely see from the work that has been done today that a lot more needs to be done in sort of hand-holding the implementation, making sure that we don't create further fragmentation. And I think that goes also, for instance, with the implementation of the European Health Data Space, which I also foresee that there is a different level of maturity in different member states with regards to what kind of data that you have and how far you have progressed with regards to your end destination. I agree with Clara that we do have so many things that we can work on in the EU, with having the possibility for long-term follow-up, having excellent registries, having also electronic health records that could be used in a much better way. I think that when it comes to using new technologies, AI will be discussed further on, but already today, using methodologies such as platform trials, for instance, could be implemented, but it also requires a willingness also from both public parties to invest and also for industry partners to perhaps move away from owned solutions on exactly how you structure your data. I think it's very positive to have a life science strategy on a European level. And from a Danish perspective, we have seen that having a life science strategy to align around really can bring you results, because it brings everybody into moving into a shared vision, so to speak. So I'm cautiously optimistic, and I do think that we need to focus on what is it that we want to achieve in the EU, not only looking at what do others do, what is the competition, but really see what is it that we want to achieve, because in the current geopolitical climate, that is, we need to make sure that we are resilient also on our own.
Excellent. Thank you, Marianne. So, pretty uniform responses, cautiously optimistic, but still plenty to be done. So let's shift on to this question of trying to create this one system, one Europe, right? A more unified approach. And perhaps, Martin, I'll start with you here, because you've also mentioned the fragmentation and efficiency issues, and the aspiration is noble, but the journey is going to be hard. So what are some of the innovations, I think particularly on the regulatory front for a company like Novartis, that you think would have the greatest impact in moving us towards that aspirational goal of a unified European system?
Well, if we think about the 27 member states plus the EEA, you could imagine that there are 27 different systems. But actually, the reality is that there are multitudes of 27 systems, because when we think about running a trial in one country that has a multitude of ethics committees, you're getting different responses from different ethics committees for sometimes a very similar trial. And then you multiply that again whenever you consider clinical research that involves a medicine and a medical device and or an IVD, or a genetically modified organism and a GMO, or indeed a radiopharmaceutical, where you're running down different regulatory frameworks for those types of products or types of aspects that are included in clinical research. So, we're a long way from kind of a one region, one ecosystem clinical research pathway from a regulatory perspective. But without getting too negative, and it's been said before, the building blocks are there in Europe. We've heard the healthcare systems, the data, the real-world evidence that we could apply. We've got the large, diverse population. We've got experienced regulators, academic centres of excellence, and fantastic investigators. So the building blocks are there for a fantastic system. And I mentioned the clinical trials regulation. Its aims are noble. You know, it's simplify and streamline, reduce bureaucratic administrative burden, and if you don't mind me reading, it's establishing one single set of rules directly applicable in all EU, EEA countries for the processing of clinical trial applications. Now, that hasn't happened. I think it's clear it hasn't happened yet.
Yeah.
And there are some moves. And I think I should commend the Commission, actually, for driving some of these forward. And the aims are still essential. You know, they really are essential to make sure that we do remain competitive and attractive for clinical research. And I mentioned before, there seems to be an interpretation and an implementation issue, which I guess could be related to an accountability issue and an ownership issue. So really what we want to see is a removal of these varying interpretations, because you mentioned at the start, Simon, we are losing ground. We're losing ground in terms of percentage of global trials set here, but that equates again to patients. So that's 60,000 fewer patient places available in the EU over the past decade. So it matters. And I mentioned some of the initiatives already in place, like ACT-EU, simplification of the IT system, which is moving in the right direction as well. It's far from optimized, but it's moving in the right direction. So again, kudos to the EMA for making that happen. And indeed, kudos to the member states and the Clinical Trials Collaboration Group, who are working very hard to try and address those urgent and immediate problems. What we do need to see is something transformational, though. I believe the Biotech Act and we have responded and will respond, Maria, I promise. There are some ambitious proposals in terms of clinical trials that are coming from the Commission, so again, commend those. So, you know, if we think about the fragmentation, moving towards a more centralized procedure for clinical trial authorization of both the regulatory and ethics aspects, that would increase consistency, increase predictability. Reducing the timelines. The timelines in Europe are in excess of 110 days to approve a clinical trial. Compare that with China, which is 30 days. Compare it with the UK, which is 30 days for initial review. And of course in the States where it's 30 days. So that, again, reducing timelines would have an immediate impact on competitiveness. Moving towards a core dossier approach. So for example, a product-driven approach to clinical development rather than a trial-by-trial clinical aspect. So currently, we submit a dossier package per trial. It is assessed per trial, often duplicated. The second trial might get new questions. If you have a trial running in 5 countries and add a 6th country, you could get 30 pages of new questions, even though it's considered safe in the other 5 European countries. So removing that variability would be really important. And the approval of the trial is the start. So the submission and approval review is the start, but actually after approval, it's also very important that the trial starts and is recruited and delivered in Europe. So elements that will help with this site contracting, kind of harmonization of that across Europe, and helping to recruit patients. Again, some work has been done in the past couple of years with the clinical trial map that allows patients and healthcare professionals to see where trials are running close to them. So that, again, that might help with recruitment and really improve the attractiveness of Europe. And then just finally, we're talking about clinical trials, but again, clinical trials is a unit of development, and we have to think about the end-to-end process in Europe. So, improving the scientific advice offer for developers in terms of, is an individual trial safe to run, but also, are you on the right track for development? Currently, there's a gap between these two, with the member states offering clinical trial advice on the individual trial, but EMA offering advice on what's relevant and appropriate for registration purposes. So really helping to pull through development right the way from innovation to patient access would be really important moving forward.
Okay, thank you, Martin. So I'm going to turn to Marianne next, and then invite Clara and Pilar to give some thoughts on what you're hearing. But Marianne, I mean, the number of the issues that Martin has raised, something that I think you've been trying to address through Trial Nations activities within the context of the Danish national system. And this question of alignment between EU and member state level is obviously a critical one. I think many would argue it's at the heart of a lot of the fragmentation and inefficiency issues. So are there any key lessons that you can share from how you've been approaching this in the Danish context that could apply to future European policy choices and decisions? And also this question about how to align different stakeholders around a more common agenda, not just taking into account patient concerns, but also the wider issues of data, of safety, of industry involvement, and so forth. What can we learn from Denmark about doing this better?
Absolutely, thank you. And I think that there are good examples from all over Europe, but coming from the Danish agenda, what Martin is saying, it resonates so well, because it is what we also see. And the way that we are working with addressing different things is that Trial Nation as an organization, for those who do not know, it's an association. We are a part of the Danish Life Science Strategy, and has been from the first Danish Life Science Strategy, which was approved in 2018. So we invite actors who work with clinical trials and want to advance clinical trials in Denmark, meaning that we have life science industry with representatives from both pharmaceutical companies, CROs, medtech companies, logistics companies, representing the different aspects of what you need in order to run a clinical trial from an industry perspective. We have all the hospital owners on board. We have patient organizations, we have researchers, and we have the two ministries, the Ministry of Business and Financial Affairs and the Ministry of Health. So that means that together we represent the clinical research, meaning the clinical operations part of clinical trials. As a neutral part, Trial Nation can invite different actors around the table to help co-create solutions. And I think that that is really one of the key aspects, that we have a neutral platform where we can invite different actors to provide their perspectives, because our experience is that you really need both a deep sectorial knowledge in the nitty-gritty details, because that's typically in the interpretation if it falls into alignment or fragmentation. You also need to have the understanding of the legislation, and here I'm thinking of where are the contradictions in country-specific legislation versus, for instance, currently the clinical trials regulation. And those gaps, they need to be addressed. I know other countries are also working with this, identifying where are the roadblocks. Can there be exemptions made for clinical trials, for instance? And this sort of engine is and model is really helpful in clearing the roadblocks. For instance, to give an example, we have looked at pieces of legislation, and again, we are publicly funded, so we are not sort of doing any political work. But what we do is that we have the deep sectorial knowledge and work together with different actors with how could you work with your country framework to work better in concordance when it comes to clinical trials. We've also worked a lot in providing avenues where you can have pre-approved contract templates or with sponsors who perform huge volume of trials, that they can have their own company template to, again, have a predictability in the contracting process. And we also work typically together with both companies, the service providers, and the research environments in tweaking the little things. which again makes a difference. Then again, coming back to the fact that we have a life science strategy and the shared vision, that is really impactful because it really helps aligning towards the same goal. And one of the goals is, of course, the number of clinical trials, because clinical trials could very well be a patient's opportunity and choose a choice between life or death. We have we see clinical trials not as a separate activity, but it's actually one of the treatment choices that the patient could be offered in the disease journey.
Okay, thank you, Marianne. Very helpful. Now, let's turn to Clara and Pilar for any immediate reactions on that. I mean, we'll start with you, Clara, because obviously you've had a role for many years within the Stockholm region, right? So going one level below the national context. Is there anything from your experiences and also what Marianne has shared that would address some of the challenges or the opportunities that Martin's presented?
Sure.
And then Pilar, also from the context of looking forward, what are some of the key points you can take from this to say, this is where we should also act? Clara, you first.
Thank you. I think below the strategic level, I think one challenge, so we have lots of innovators and researchers who are doing fabulous things with AI and health data at the moment, but they are hampered by the next level in the AI cycle. You know, going back to clinical trials, we know first you have a phase 1 and then you have phase 2 and and there's a whole system for quality assurance that everybody knows. It creates a lot of security. We know that when products have passed through these steps, they're trustworthy, etc. We don't have that in place for AI algorithms or AI-based or associated or augmented work as of yet. We have some really early people in Stockholm who came to me 5 years ago and say, where can I validate my algorithms? and we had no answers on the regional level. And the region said, oh, we don't have time with that. We have a pandemic to take care of. So I think if we could get that in place, kind of a framework, a regulatory framework that is part of the bloodstream, you know, that we actually agree on, not something that's in an act somewhere, but that's something that is part of the daily work. I think that will be very, very important. So if I ask my researchers, what's your main challenge? They say data access, but they still have data to work on. So they're working on the data they have. They want more, they want it faster, they want broader type of data sets, they want to share it, etc., but they do work with it. So the next step is to validate their algorithms, then they need a different data set. How do we get that? How do they sell their products to healthcare? That is, how do you procure AI-based products or AI-augmented products? How do you qualify, how do you have the quality assurance process for that? So if we could get more of that cycle going, I think that will be a very important next steps for the things we already have. We have fantastic things that could actually get out there. And then, of course, there's a lot of complaints about MDR and too few notified bodies and all the complexity and all of that. But I think one important aspect that you lifted is that also the unified interpretations of what is anonymity. Sweden has a very tough regulation on anonymity, which means that we sometimes can't do things that other countries in the EU can do. So we need and I think that would, if we could agree on that, it would be easier to share data and use federated solutions and all of that. And I think also some fast actions that could make a difference in the short term, like EU-based cloud solutions that are safe and that our lawyers would say these are okay to use. Because the technical maturity is there, but the organizational and the regulatory maturity is not there. So that's the bottleneck at the moment.
Okay. The moment we bring the legal department into play, things
Yes.
get a little more complicated.
Yes.
I would imagine. Same for Novartis. But Pilar, any immediate reactions to some of the points that Martin, Clara, and Marianne have raised?
Well, I'm quite happy that the session is being recorded, because there's been plenty of ideas and plenty of things that I want to go back and reflect on and capitalize on. I think that there are, if I may say, the way for me the take-home message is first the hurdles of today, that are the ones that I think the two first speakers have identified very well. And I think that what is true at the level of country, we can see similar problems or similar hurdles and possibly similar solutions at the European level. It's about the fragmentation, it's about different interpretations of the same pieces of legislation, it's about disconnection or lack of connections between the different actors. And I think that those are the issues that have been, in a way or another, identified also in the European Life Science Strategy, and those are the block roads that you mentioned, Marianne, that we have to address now. And you've mentioned also how important it is to have all the actors around the table, and I think that this is something that we really share, and this is why I mentioned we do not work in Brussels in isolation, in obscure desk and offices. We know that better than that, and we know that we absolutely must work with the member states, for example, who are the ones implementing a number of things, the regions, with the hospital networks, with care associations, with patients, with a number of people. So those are the hurdles of today that we are hopefully going to start addressing also at the European level. Then there are a couple of reflections that I think are very wise from you, Clara, is the hurdles of, not tomorrow, but the hurdles of the day after tomorrow, not of today, because you just mentioned how important it is to be prepared, not only at the technical level, but also at other levels, like regulatory levels, but also interpretation or level. So I think that is important that we've put a lot of effort, all of us, on the European health data space, and it's becoming a reality. But I also understand that as we look with all the initiatives that have not been there for very long, it's important to basically to work together and to eliminate those difficulties. As you mentioned, the interpretation in Sweden is different from the interpretation in other member states, and that may hamper also somehow. I want to remind you, the motto of Europe is united in diversity. Diversity makes us very strong, very rich. It also means that we have to learn to work together, coming from different places. And I think I'm old enough to remember places or things or areas where this common interpretation or this fragmentation was very visible. Let me share one experience. I know this is oversimplification, but the ones around the table who are older will remember the days where you were traveling around Europe with your first mobile phone that was this big, and then you call your family and say, I have arrived, I'm fine, don't call me. Because roaming was, Jesus, hundreds of euros. I've paid hundreds of euros on that. And it took us a long time, really, absolutely, 5 years or more to get to this. If I tell that to my niece, who's 21, it's like, what are you talking about? But, what I want to illustrate with that is there has been a lot of progress in Europe in, bringing together the different countries, bringing together different actors, and improving and paving the way for innovation and for well-being and for competitiveness. I know that this is an area which is much more complicated for a variety of reasons. I know this is an area where there are also other actors, and we're talking about something very important, very difficult, and so on. It's not only about clinical trials, which has been the matter of this. It goes beyond for us in life science, but I acknowledge that it's not easy. But the good thing, and I think that it was you, Marianne, who said, and there is an alignment. Everything is aligned now. I haven't met anyone that has, is not willing and has identified the same hurdles and is not willing to come forward and find solutions. So I think the moment is there. And I want to capitalize on a number of ideas of my co-panelists, because I think they represent really a wealth of knowledge.
Very good. Thank you, Pilar. Now, we're not finished yet, so there may be more to come. We certainly hope so, because it's now time to welcome Tomislav Sokol from the European Parliament, who has finished voting on how to unify the single market in Europe, we hope. And Tomislav, I hope that you can see and hear us. We're just waiting for you to come on screen. But it's very important for us to get a perspective from the Parliament in today's discussions, and in particular from somebody like yourself who has been very actively involved in a number of the critical pieces of legislation and the broader political debates in the last couple of years, from the GPL revision to the Critical Medicines Act and also the European Health Data Space. So, Tomislav, I mean, if we look at the impact of current and forthcoming legislation under development on the wider life sciences R&I ecosystem in Europe, what do you think is at stake, and what happens if we don't get it right? How can the Parliament also help to ensure that we have the most innovation-friendly ecosystem and regulatory environment in Europe for life sciences? Tomislav? Oops, let me check. Okay, so apparently they're having a connection issue in his office. He'll be with us in just a moment. Apologies if I have to repeat the question. But, okay, Clara, we'll move on until we have Tomislav in front of us. Let's come down one more level to hospitals. Right? And of course, Karolinska is one of the shining lights within the European and arguably the global life science ecosystem. This interface between research, clinical trials, patient care, health policy and funding, and also partnerships with industry. Beyond what you've already talked about regarding AI, data usage and so on, are there any other perspectives from a hospital, a research hospital view, that you would like to see as the life science strategy is implemented and also the Biotech Act developed, that would really strengthen the impact of the work that you and colleagues are doing?
I think my answers will be the same. It's still health data access, computational capacity, regulatory framework, all those things that will impact all the levels from the university to the clinical bedside. I think what actually opens up with the new digital health data system is, or access to digital health data, is also that we can do things more related to systems research in the hospital, logistics in the hospital, care, patient flows, etc., that really can help and improve for patients. But I think one important aspect, if you look at university hospitals, is that patients are not there anymore. They are in outpatient or primary care or at home or in the community. So if we are going to reach out to all the entire populations of patients, both for trials or for access to supports or devices or whatever, we need to move outside of the university hospitals. And that's a bit of a challenge for the university hospitals because they used to own everything. They had the patients there and they had the research there and they didn't need to bother with the systems outside. Now the patients are moving all over. So we need to develop our systems to follow our patients across organizational boundaries as well. It's a challenge in Sweden, but we're working on it. But it is a challenge. With the EHDS actually pushes that in the right direction. So I think, but still the university hospitals will be the hub for pushing forward But many research issues and health issues and quality of life issues will need to be addressed otherwise or outside the hospital systems, because you come in for a very advanced treatment. And also that specialist care, we need to do things in other care levels as well. So we need to look at this as an entire ecosystem. And it's a shift that's been going on long before health data and AI, but it's going faster now because of so when I train as a doctor, the patients were in the hospital for a week after surgery. Now they go home after 24 hours. Or maybe in the same day. So then, if you want to follow up your patients, that's a challenge. So that's also a shift, the mindset that we are in the midst of. So things are moving in different ways here, and we have to try to really identify how to, optimize the systems despite all the changes.
Okay, super. So Martin and then also Marianne. Tomislav will be us in 2-3 minutes. But this question about the role of research hospitals, university hospitals in your research and innovation chains and ecosystems. Do you see the same patterns of disruption? You're having to rethink the way that you partner with institutions like Karolinska in this R&I value chain?
Yeah, I was just reflecting on what Clara was saying about the decentralization of trials across Europe, and it speaks again, if you're I'm struck as well about the beating heart, and data is probably the blood, that has to flow, kind of safely between institutions, between countries. It also speaks to the rise of digital health technologies, and again, an integration into clinical research of the medicine with maybe the follow-up or even the endpoint of the investigation being discovered via digital health technology. So how do we regulate those? And I think Europe's in a very good place for that, because we could have a system where digital endpoints are robust and validated here. So, you would come to Europe to kind of run a decentralized style trial, perhaps crossing borders, perhaps, kind of following up, starting in the hospital, following up in community. So again, I think we're uniquely positioned as long as we can really grasp that opportunity.
Yeah, I agree. That could really be an added value in Europe. I think so.
Would you agree, Marianne?
Yes, I was actually thinking before we started on this particular topic that I'm also of the generation where please don't call me once I cross the country border. And when you live on a country border, it becomes even more complex because your network might change. So I'm very happy about that. But there are a lot of things that has happened, for instance, when it comes to prospective clinic, the traditional pharmaceutical, prospective clinical trial, and data. They used to be complete separate entities, and now they are sort of merged because both in the technical capacities, but also with the need of following patients in highly selected populations, for instance. So they are really merged into one in a way that it wasn't before. And another thing that sort of healthcare or having solutions, and I'm now thinking of different algorithm-driven solutions. The development and the production, that line is also a bit blurred, because if you have an algorithm, it's not enough to develop it. You need to have access to data to make sure that your algorithm doesn't drift and that you're still in production. And in some cases, those legislative rooms, they might be in different places. Also, when it comes to systems and how you use systems, the whole IT/legal interface needs to be addressed, because very often you might take a decision and it's very much based on production, and then you realize that actually we need to use this system also in research, and you might have a different question. So that needs to be thought in. When it comes to the decentralization that we just talked about, and the patient flow, I think that we see that in many European countries, and also in Denmark, where we have a healthcare reform which is underway and which will be implemented in 2027, where of course it's most bang for your buck if you can first keep people healthy, and if you can't keep them healthy, treat them in primary care rather than in secondary or tertiary care. In Trial Nation, we've worked with decentralization and how to work with national models since 2022, looking at different aspects. And that could definitely, for sure, granted that we agree on data standards, etc., that we agree on the actual implementation of legislation, the operational harmonization of implementation, to also work across borders. And I think it's also definitely something that we see, that you need to think about the patient and the patient journey rather than a particular unit who's very skilled in clinical trials, which traditionally has been university hospitals or specialized clinics in regional hospitals, taking Denmark as an example. And that's also something that we are currently working on. How do we work together with primary care, because there is research interest in primary care, but how do you make sure that you have a support unit, making sure that you have the skills and the volume, because you might have individual units who are in themselves too small to be a traditional clinical research site. So that is definitely something that we're also working on, not having an implemented solution yet.
Great, thank you, Marianne. Now, connectivity issues with the Parliament have been solved, so we can now repeat the welcome to Tomislav Sokol. Tomislav, I hope that you can see and hear us. We're waiting for you to appear on our screens, but very good. Nice to see you. It's a busy morning already for you.
Yes, thank you very much. Yes, we just had an event on brain health and health literacy, so a lot of things going on related to health. But I'm glad that I will be able to speak on such an important topic here as well.
Great, thank you, Tomislav. So in the interests of time, let's cut to the chase. There's a huge amount of legislation currently under development and forthcoming, whether that's GPL, it's critical medicines, life science strategy, but also the Biotech Act. What do you see as the key priorities through the lens of the work the Parliament's doing to make sure that Europe remains as innovation-friendly as possible for life sciences in the years to come?
Thank you very much. So definitely we have to start from the objectives. And I would say that there are two basic objectives. The first one is strategic autonomy, less dependency on the others. And because we see how much of a problem it can be, if, especially in case of crisis, if you depend on imports of medicines from third countries. Here, Europe is more in danger than when it comes to generics than innovative medicines. But on the other hand, we have enormous push now from China. So China investing strongly into clinical trials, bringing clinical trials to China, investing into innovative medicines, etc. But also what we are seeing in the US, where the new administration is putting enormous pressure on individual companies to restore enormous amounts of investments to the US in the next several years. Of course, not all pharmaceutical production can be transferred within 1 or 2 years. It's something that is complicated. It's a highly technological process. It takes a long time, but the trend is clear. If you don't do something on the European level, in 10 years' time, we'll have enormous lack of investments, enormous gap in investments in production facilities for innovative medicines in Europe, while US and China will definitely have almost a complete monopoly. So this is something that we cannot that cannot happen. We cannot let that happen. We unfortunately accepted this unilateral deal whereby US is entitled to impose 15% tariffs on innovative medicines from the EU. I'm not a big fan of that. I've been saying that all along. I think European Union should have used the leverage that it has to get a better deal. But anyway, the situation is as it is. So we have emerging China, dependency on imports of generic medicines and APIs, pressure from the US administration to bring production to the US, and on top of that, 15% tariffs for innovative medicines. So this is the broad context, and in general, global geopolitics that has become more focused on force instead of rules, instead of implementation of regulation, instead of trying to find compromises, etc. So in that context, achieving strategic autonomy and bringing as much production to the European Union and being less dependent on the others is essential. What we are concretely doing. So European Parliament's position and my individual position in the GPL was to strongly defend at least the current level of regulatory data protection and market exclusivity. And this was our position from the start, even though you know that in the original Commission proposal several years ago, they wanted to reduce it to a significant extent. And if we on top of all of what I mentioned before, all the problems that we have, if we on top of that also reduce regulatory data protection by 2 years, that would have been a disaster. So our position was clear: protect the market exclusivity, protect the incentives, at least on the level that is in force now, on one side, but on the other side also make sure that generic medicines can get to the market on day one after the protection expires. And I think we were able to achieve this compromise at the level of the Parliament with protection of the RDP on one side, but also strong border exemption on the other. And I think also Trump's election win and everything that he's done so far has also resulted in the compromise in the Council, because I know that Council was deeply divided, essentially along east-west lines, where eastern countries who depend more on generic medicines, on generic industry, and who have bigger problems in terms of funding the health system, they were more in favor of reduction of the exclusivity in RDP, but they realized that within the context of the new US policy, we have to focus more on competitiveness of European Union, and for that reason, I think they were also able to find a compromise which is pretty close to the Parliament's position. But without the US policy, without the tariffs and everything that Trump's doing, I don't think that Council would have ever come to such a balanced approach that they have now. So I think we are pretty close in our positions. So I think these two things are interrelated. So RDP on one side and the more exemption on the other. And I think that we should try to find a compromise along the lines of the Parliament's and Council's starting positions, but without reopening too much of it, because I'm afraid if we reopen it, then we'll have the divisions between different member states, and then it will be impossible to come to an agreement. So, but I think this is essential. The other important thing in the GPL is about access, and because we know that the differences in terms of access to innovative medicines are enormous. That 46 out of 48 of new oncological medicines are available in the biggest member state, while in the Lithuania only 3. And these kind of differences are unacceptable. So we have to have a common European position. This we cannot have such a postcode lottery. And for that reason, I'm glad that the Parliament's position has to some extent also been taken up by the Council. And I hope that this will be the end result of the negotiations. That there is a duty to provide the medicine within 1 year after member state requests it. So the Parliament's position here was that we don't want to penalize the industry for something that is outside of their control. For instance, if you file for reimbursement and then it takes a long time for the national health insurance funds to come up with the decision, that the developers of medicines should not be penalized because of that. So in our approach, we have a legal duty. Member state makes a request if it thinks that it requires a certain medicine, and then the developer has 1 year to put it on the market. And so I think, and I hope that the final approach will be along these lines of the Parliament, so to ensure equal access when there is a necessity for the medicine, but without penalizing developers for something outside of their control. When we speak about Critical Medicines Act, here the priority is to bring as much of production to Europe as possible. This is why we introduced the so-called Buy European preference. That is what is already in the Commission proposal, that those companies who produce in Europe, who have a significant footprint in Europe, should be prioritized in case of public procurement. So that the lowest price is not the only criterion, but that we have other things, so the meet criteria as well. In my draft report, since I'm the rapporteur there, I propose to strengthen these meet criteria, to clarify what they are, so to be much clearer in enumerating what are these other criteria apart from the price, to be precise on that, so that we give certainty and clarity for the industry and for everybody else, that they know what criteria there will be. So that's the first thing. Second, Joint procurement. I know that industry is pretty skeptical about this, but joint procurement is a big political priority for the majority of the member states, also the majority of the parliament. What we want to do with joint procurement is we want to clarify some things, to simplify some things from the original Commission proposal that were not clear. But what we want to also give, let's say, to the industry is binding quantities. So the idea is that if binding quantities are part of the tender for several years in advance, then you can make plans. You can adjust your business plans to aggregate the demand of several member states, and definitely by doing this, we are giving clarity and certainty to the company so that they can plan in advance, several years in advance. This is especially important for rare diseases, where aggregated demand of several member states will be able to, I hope, create a market. And with binding quantities, we make sure that the industry also knows and can make plans and that the whole system is predictable. So that's about joint procurement. I already mentioned the public tender preferencing strategic projects. So this category of strategic projects is now part of the proposal. The idea of that is that this can be that this can benefit from faster permitting, so easy procedures to start to build production capacities much faster than it is now. What we want to have is European coordination, so that we know where different capacities are built, that they don't have overlaps, they don't have duplication. This is why we want to have a control from the European level for strategic projects to make sure that they are allocated in the right way. And the last point is about stockpiling. This is extremely important because the national stockpiles lead to shortages in other member states. We have the data which show that. And for that reason, we want to create a common European system of exchange of information so that we know on the central level what the situation with stocks is in different member states. And in case of shortage, that decisions can be made of reallocating medicines from stocks in one member state to those member states which have the shortage. So we are not imposing obligations on the member state to have stockpiles. We're not telling them what to stockpile. We're just creating a European coordination mechanism to make sure that we exchange data, that we know the situation in different member states, and in case of shortages, that medicines can be reallocated as soon as possible to those areas where the need exists. I know that there will be opposition from some member states on that, but for us this is a high political priority because we want to make sure that all European patients can benefit from medicines at the same time.
Okay, Tomislav,
I think to sum up, we have two priorities. One is strategic autonomy, competitiveness, and everything related to that. Stronger incentives by European preference, faster permitting, easier procedures, etc. And the other side, making sure that we have equality of access. And if I have more time, I can speak also about the Biotech Act and revision of clinical trials regulation, which I think is also an important topic. We have the latest information that this is postponed to second or third quarter next year. So instead of rolling it out by the end of this year, we received and we saw certain documents which implicate that this will be postponed for next year. And let's just hope that we get it right. I know that the commissioner has the idea to put revision of clinical trials regulation in the Biotech Act. I think this is an interesting approach. Clinical trials regulation needs to be revised, needs to be simplified, procedures needs to be streamlined and more harmonized, especially relating to the ethics procedures, etc., etc. Of course, without jeopardizing national competences. But I think this is something that can be done on the European level. And what we need to prioritize and incentivize is cross-border clinical trials, that they are not concentrated in a few big member states, but that all parts of the EU can benefit from clinical trials, and patients from all member states of the EU can benefit from clinical trials as well. So a lot of us to say, but we probably don't have the time. I saw that.
I'm afraid we don't, Tomislav. But thank you again for the clarification on the Biotech Act timeline, because that's something that we're going to look at as a network as we move into next year when we get closer to the development of the draft proposals. But we do need to bring the session to close in a couple of minutes. So I'm going to thank you very much for your time this morning. Very pressurized agenda, but next time we'll see you in person, I hope, when we carry forward these discussions.
I also hope that will be the case as well. I think this is one of the most important issues now in the European Union. I think pharmaceutical and biotech sector are the most important strategic sectors for the EU, with the highest added value, with the strongest export, especially when compared to the US, for instance. It's highlighted in the drug report as one of the strategic sectors, and I think it does not get enough mentioned in the media on one side, but also on the priority list of the Commission. Unfortunately, I don't see that the biotech sector and the health sector in general have the priority that they deserve. And I hope that we'll be able to fight together on this. As I said, I think this is one of the two or three most important strategic industries in the EU. And if you don't get it right, if you're not able to protect competitiveness of the European industry, then in 10 years we'll have enormous problems in terms of access to medicines, in terms of shortages, in terms of dependency on the others, possibilities to blackmail us. And for that reason, European Union needs to pull its act together and do all of the things that I already mentioned.
Message well received. Thank you, Tomislav. Now, it's time for us to wrap. Pilar, I'm sorry we didn't get to talk about the clinical investment plan,
Next time.
but we'll come to that next time. Martin, I'm going to give you the last minute. Just any key takeaways that is really going to inform your thinking and work.
Thanks. I think this has been a fantastic discussion, and thanks to the colleagues for their views. I think we have to think of clinical research not in the abstract. Think of it as the end-to-end development of a product that will reach a patient. So, we've mentioned fragmentation, we've mentioned disharmony. So really move towards grasping the opportunity of the Biotech Act and whatever other levers we've got in Europe to have a more central coordination of clinical trials of both the regulatory and the ethics perspectives, and that will open up trials to all countries in Europe and to all patients in Europe. I think that's a really great way forward. Reduce the timelines involved in clinical trial assessment, help with startup in terms of contracting, site approvals and recruitment, and move towards a product-based approach with more facilitated pathways so that we can draw innovation from research to development to patient access.
Wonderful. That's a great note on which to finish. So, please join me in thanking Clara, Marianne, and Tomislav online, Pilar and Martin for all of their contributions. That's your cue. Well done. And we're going to take a short coffee break, and we will recommence at 11 o'clock with our next session on the RNI value chain and strengthening the ecosystem in Europe. So, enjoy your coffee, and thank you to our online audience. We'll see you again at 11. Welcome back, ladies and gentlemen, and also to our couple of hundred participants watching proceedings online. So it's time for us to move on with our agenda. Great discussions about clinical trials, clinical research, but that, as we said, is the beating heart of the RNI ecosystem. And in our next session, we're going to talk about the ecosystem itself and how to strengthen RNI value chains in Europe. So to guide us through that fascinating topic, I'm going to give the stage to my colleague, Eleonora Francica, from the Science Business News team, who's going to moderate the session. Eleonora, tell us what's in store.
Thank you so much, Simon. Good morning, everyone, and welcome to our session, Missing Links, How to Optimize the Life Sciences Innovation Value Chain. So, I hope you all had your coffee, because I need your energies here. We're going to ask questions from the audience. As we all know, Europe's life sciences, it's very strong at research, but weak in translation. So in our panel today, we are going to find out how this is possible and what we need, what the EU needs to have a more competitive, a more connected, a more impactful life sciences value chain for patients and for the society. Of course, I will not be here alone, and I will have 4 experts that will help me in diving into this discussion. So please welcome Niklas Blomberg, Executive Director of the Innovative Health Initiative, Jonathan Eubank, Director General of the European Research Infrastructure on Highly Pathogenic Agents, Nancy Cotigny, Member of the Board of Directors at BioVia, Founder and President of Ad Hoc Clinical, and Lara Pandia, Team Leader for Strategic Partnerships and Communications at Global Health, EDCTP3. Okay, so let's dive straight in with some quick opening thoughts from you. As I already said, the EU excel in research, but struggle when it comes to translating that excellence into innovation and real-world impact. So from your perspective, what are the top 2 or 3 missing links in the value chain that Europe most urgently needs to fix to stay globally competitive? Who wants to start first? Maybe Lara?
Sure, thank you. And thanks very much for inviting Global Health, the EDCTP3, to be here today. It's an important discussion. I'd say that the key challenge is not about lack of excellence, it's about connection. And while Europe is strong in research, maybe some of the missing links are around the fragmentation in funding, priorities, regulations, and interventions. And to tackle those, first, we really need to strengthen long-term strategic international partnerships across both public and private sectors, particularly in the life sciences area, which has high societal value. So we're talking about infectious diseases, neglected diseases, antimicrobial resistance, epidemic preparedness, where there's a low commercial return, and then a risk that these might fall through the cracks. And the EU life sciences and global health strategies both recognise the importance of joint investments across public and private actors to accelerate and de-risk research and innovation. And secondly, I think we had to keep Europe's research ecosystem open to the world, because openness attracts global talent, investment and collaboration, and expands our capacity to turn research into real products. It also increases Europe's competitiveness. And instruments like Global Health EDCTP3, which is the organization I'm representing, are good examples of how we can reduce that fragmentation to deliver impact. To do so not only amongst European countries, but also with governments and international partners. And we're a partnership of 46 European and African countries. And we sit together to co-create and research funding agendas together with the European Commission. And that's strengthening coherence, aligning priorities, fostering ownership, and leveraging investments more effectively across Europe and Africa. And we've seen the transformative power of that partnership because it brings to life groundbreaking innovations such as the first malaria vaccines that we have in part supported the development of, and we hope to see this momentum over the years. And finally, I think it's about needing to improve translation mechanisms. So connecting research and development with regulation, manufacturing, and market access, and that means strengthening coordination along the value chain and, where possible, streamlining funding streams. Europe has strong science, but it needs to build stronger bridges between the research and the market, between public and private sectors, between research and development funders, development cooperation funding, and between Europe and the rest of the world. And partnerships like EDCTP and also IHI, which I'm sure Nicholas will chime in on, they have a role in bridging these gaps and making a more coherent and effective life sciences ecosystem. And why is that important? Because life science is inherently global, and infectious diseases do not respect borders. And so Europe's competitiveness will really depend on how well we connect within and beyond those borders.
Thank you so much, Lara. And since you mentioned IHI, I will ask Nicholas to jump in with his opening thought.
Thank you. So I think I'll build on what Lara says. I think there are two areas we need to look at in Europe for partnership, and I think what is really challenging. We talk about excellent science. We want to translate that into innovations that benefit the people, the society, and the healthcare systems. And I think that connection is really quite challenging. And if you think of healthcare innovation, it's challenging because you need to bring together a lot of different stakeholders. You have the research, the innovations, but it's also the regulation. We need to make sure that interventions are safe and effective. We need to look at the organization. So how does that fit in to the whole system, and what are the reimbursement models that can support the innovation. So I think when you look at bringing research to innovation in healthcare, it's really about bringing together a lot of different partners. It's the healthcare systems, it's industry, it's research, but also civil society, patient organizations, many of the foundations. So I think that's a really important area to strengthen for Europe, and to sort of connect those partnerships to be able to translate the research into sort of innovation. I think that the second area we really need to look at, and clinical trial is a good example, but this holds true also for, say, data, is to turn what is actually, I think, Europe's biggest challenge into a competitive advantage. And so what is currently quite difficult in Europe is to do activities at scales across the countries. If you look at clinical trials, the area where if we want to run big studies in Europe, we will need to do multi-center, multi-country studies. That's the area which is very difficult. It takes a long time to set up. I think it's the same in data. If we want to build, say, a big research cohort, we need to go across European countries, and that's very difficult. It takes time. And if we can overcome that and find ways of sort of turning this disadvantage into strong collaboration between the countries, if we become good at setting up multi-country clinical trials, then I think, and this is the connection to the global health, then we can also be a trusted partner globally, because if we can do it across 20 European countries, there is no reason that we can't bring in partners from the rest of the world. And as Lara said, the challenges are very, very similar. So I think those are really the two important areas to focus on.
Thanks, Nicholas. Clinical trials. Nancy, I think you're dying to comment on that.
Oh, yes. Well, I think that we are good at clinical trials, and I think it's been proven, everybody knows that. So we have this expertise, we have done it on a pan-European, worldwide level, so we can analyze what happened there, what went well, what went wrong, and try to export this knowledge to the putting drugs to the market. There's lots to learn. So if you ask me what the difference is between research and bringing things to market and what the gap is, well, I'm preaching to the choir when I say regulation, please simplify it, but I've heard this like for the past hour and a half, so I'm just going to emphasize on it and say, yes, please do so. There's obviously a bit of attention needed in funding, not just the clinical research parts or the early research parts, but also the bringing it to the market. And here we do have a gap. And then a last point that I'm reiterating, and everybody seems to have the same bullet points on their own lists, is, of course, reimbursement and market access. The one doesn't go without the other. You cannot expect having a lot of clinical research in your nations and in your country if it doesn't boil down to actually bringing those innovative drugs and medical devices to our patients.
Thank you, Nancy. Jonathan, I'm so sorry I left you the lad.
Somebody has to be last. There's no worries at all. Thanks for the invitation.
It's an art position, because you already heard so many, like important bullet points, let's say. So please.
That's true. And I'd like
what do you
come
think?
Come back to some of those. So Lara started by talking about connections. So I'm here not only representing ARENA, but all the different life science research infrastructures come together under an umbrella organization, which is the Life Science Research Infrastructure Strategy Board. And that's because there's a belief that working together, we all benefit and we can move forward in innovative solutions for real social problems. Now, when the research infrastructures were envisaged by the European Strategy Forum on Research Infrastructures, ESFRI, it was for excellent access for research, for scientific, basic science, and ensuring that access. It wasn't really for product-oriented validation. But nevertheless, many of the research infrastructures, because there is this continuum from basic research through to the market, are and have been actively involved with industry. So there is the European Research Infrastructure for Translational Research, EATRIS. Elixir, that Nicholas was in charge of, had a lot of connections with industry as well. Arena does. And there is even IBISPA, which is a biotech accelerator with pilot plant capacity. Now, more recently, there has been the establishment of the technology infrastructures. And this has slightly confused the landscape. So it would be very good in the future if there could be some clarification of what is the expected roles of these different instruments that exist and are being set up. You've heard a lot about regulation. Yes, there need to be mechanisms for making sure that the people who are doing early development get in touch with the regulators, and there's that two-way discussion between them. We need to have better interactions between the research infrastructures and potentially also the technology infrastructures with existing instruments, like the IHI, industry consortia. Why not imagine having some coordination layer between research infrastructures and in industry? And then lastly, for Arena, we've heard about infectious diseases. So there is in Europe the capacity to do work in high and maximum containment laboratories, but there's no link then to the necessary GMP capacity. And so that's a missing link in the value chain for the development of innovative medical countermeasures for infectious disease.
Thank you so much, Jonathan. And you gave us so many fantastic examples. So thank you all. That gives a great foundation to start our discussion. Let's go now a bit deeper on the key parts of that value chain and hear more concrete ideas on how we can make Europe's life science system stronger and more connected. So, Nicholas, I will start with you. You lead the Innovative Health Initiative, one of Europe's flagship public-private partnerships in health. And from your perspective on the future of IHI and partnerships, what's worked well so far? And what needs to evolve to strengthen the EU's position in life sciences and health tech from, forward? Moving forward.
It's quite a big question.
It's
Thank you for that, Eleanor. So I think what has worked well. So IHI, we are a public-private partnership. We fund research, and half of the funding comes from industry and civil society. We have quite a lot of philanthropic organizations involved, or patient organizations. And then the other half is funded by the European Union through Horizon Europe, the European Commission. But there are many of these public-private partnerships across Europe, and I think what all of them have shown, and we have about 15 years of experience, is that you can actually bring in and productively connect industrial actors, civil society actors, and public funding to do advanced research. And it's actually quite a powerful mechanism to bring forward health innovation. We have some really nice examples. We have some very nice collaborative examples with EDCP3 in the antibiotic space, for instance. But and I think one of the particular strengths, if you look at IHI, is what we see. So about 50% of the in-kind funding from industry is people. And I think it's that expertise that really makes the strength of the program. And one of the areas we see that is work on clinical trials. I talked to Martin before. He's involved in one of our projects on more diverse and representative clinical trials. But one of the strengths of industry is, of course, the regulatory science and their regulatory bodies. And I think that's very enriching for the public partners. So I think that we have the foundations in place. I think there are sort of things we can fix around the edges, around rules and administration and so on. But fundamentally, I think Europe has a very, very successful model, both at a European level and replicated in many countries. I'm in Flanders, but I was in Denmark last week, where they have many similar sort of national and regional initiatives. If we go forward, and I come back to what I said, I think there are three areas we need to look at for Europe. So one is, of course, health innovations for unmet public health needs, and there are lots of important needs from climate change and non-communicable diseases, the aging populations, and they are shared with Europe and actually with Africa. We see non-communicable diseases heart diseases being a big challenge in Africa, cancer is a big challenge in Africa. So I think there is a global perspective there. I think the other important part the second important part for Europe is really to sort of do research to help us drive the enablers of the competitiveness. I mentioned clinical trials. We have data AI, so how do we build the large data collections? How do we use research to really drive and seed the opportunities of AI and data in health? So I think those sort of drivers of competitiveness is really important. And the last area is also what I mentioned before. I think we need to work with the healthcare systems. So how do we enable sort of the healthcare systems to absorb new innovations, because a lot of healthcare systems are under a lot of strain. There is also a large transformation of the healthcare systems. We fund right now quite a lot of projects on sort of out-of-hospital care. How do you do advanced care with telemedicine or out-of-hospital methods? Well, that will require changes into the healthcare system, and we need to bring them into these partnerships and sort of co-evolve the innovation.
You know, like when talking with you during the past week to prepare for this discussion, I felt the sense of urgency, you know, to improve this translation, the value chain in life sciences. Can you comment on that?
No, but I think it is urgent. I mean, we heard MEP Sokol before. The world has changed very, very rapidly, and of course in Europe we need to respond to that very rapidly. So I think there is a sense of urgency felt by everyone that we perhaps didn't feel a year ago. The urgency was probably there a year ago, and I think the two really big areas where there is urgent need to move forward is, of course, clinical trial and around data and AI. With the emerging European health data space, it's an enormous opportunity, and we just need to make sure we drive that forward.
Jonathan, turning to you. You represent ERINIA, a key part of Europe's research infrastructure landscape. What concrete changes are most needed to make Europe's research infrastructures better connected and more aligned with innovation and industry needs?
Yeah, no, that was an extremely pertinent question. And I think first of all, we need to acknowledge that industry is not sufficiently informed about the opportunities that the research infrastructures offer them. Europe has invested massively in research infrastructures. It's billions of euros that have gone into these structures, and they're there for academic researchers, but equally for industrial users. As a single example, so ERINA coordinated a project that was called Isidore, that was building on the capacity of all the different life science research infrastructures, and we did fund 14% of projects from SMEs out of the close to 200 projects that were funded in that particular instrument. So there is a potential demand, but that knowledge of what's out there is simply lacking. And in part, this has been recognized by the Commission, and so there are efforts to increase discoverability. And what's certain is that with the advances in AI tools, then there is a possibility that we're going to be able to allow the potential users of these capacities to discover what's there. But then there needs to be efforts to harmonize access as well, because today the different research infrastructures all operate under different regimes. Nicholas was in charge of Elixir, which is an international organization which has its own particular rules. Many of the research infrastructures are ERICS, European Research Infrastructure Consortia, and others. Others are associations, non-profit associations. So currently, there is no harmonization. That's up to us to see whether we can do something better on that. You could also see in the case of Isidore how valuable it was offering services across research infrastructures. So there was one particular company called Pharma Holdings that had support from 4 different research infrastructures for the development of an innovative medical countermeasure. And currently, that type of collaboration between the research infrastructures can be done, but it's certainly we don't have the mechanisms in place to do that with ease. One of the issues as well is about, we've heard about regulation, and the services that are offered for some research infrastructures, they are already, for example, have their ISO certification. They may be done under GMP or GLP conditions, but this needs to be harmonized and made clear what's on offer. There needs to be an alignment with data outputs, with EOSC, the European Open Science Cloud, and the European Health Data Space. There is a project being run at the moment linked with EOSC called OSCARS that brings together the different science clusters. So there's clusters for life sciences, for environmental science, for particle physics, for example, and they're all working together to develop new standards across the board. I mentioned access to regulatory advice, and that's important for those projects as well. I believe that there would be a place for having some co-funded joint industry programs targeting specific parts of the innovation pathway. So say from TLR3 to TLR7, why not imagine a project that would leverage the research infrastructures with IHA funding or EDCP funding. The other thing that is when you're developing that type of new mechanism, you need to have clear indicators of success. So we need to agree what those KPIs should be and how often they need to be reported, ideally in a harmonized way across the different research infrastructures. Many of these actions, as you might imagine, would require funding, and if you want to maximize on this investment, there needs to be some guarantee that that funding will continue so that these efforts do not turn out to be, as so often happens, a 3-year funding cycle. Investment is made in setting up some type of coordinated action, the funding stops, and all that effort just dissolves.
Thank you so much, Jonathan. And before I ask Nancy and Lara if they have comments on what we heard from Jonathan and Nicholas, I want to tell our audience to prepare some questions, because after that I will ask you if you have some questions to our experts here. So, Nancy, Lara, what do you think?
Well, I think that the point of continuity is absolutely worth stating, and it's not an isolated case. It's across the industry that expertise has been built and programs have been made, and then all of a sudden nothing happens with it. So this is an attention point that if you want to use those funds wisely, there has to be some kind of continuity.
I would agree on that. I'm not sure if this is where, it is. No, I also wanted to pick up on the point that you made, actually, Jonathan, because we do have examples of where we have jointly funded with industry and capacity development activities, really in research infrastructures. And I think this is critical, and indeed that long-term investment, we have, for example, research networks of excellence that we set up in Africa, but they work in collaboration with European partners, and there is this bi-directional learning. And I think that we funded these now over the period of 15 years, so it's not a short-term investment. And I think tying that investment to clinical research, so you're not funding clinical research in isolation, is really critical, so that capacity is there when you need it the most, for example, in an outbreak and where you need the response.
Thank you. So, our beloved audience, is there someone that has a question for our experts?
While we're waiting for questions, could I just jump in and mention that?
Please.
So there is in January, Be Ready Now will be launching, and so this is the Pandemic Preparedness Partnership. And the Pandemic Preparedness Partnership has 4 pillars, and one of those pillars is for ever-warm clinical and preclinical capacity. And what's going to be very important is that what is built in Be Ready should not just be restricted to infectious diseases, but also be used and have profit to all the other different clinical research networks that are being put in place at the moment.
Nicholas, I see you nodding.
Yeah, no, I think I think that's a really good example. But I'd like to build on what Lara mentioned on the continuity, and I don't want to steal your thunder, but so we have a really nice example of a project in tuberculosis that gone ping pong between IMI, IHI, and EDCTP3. And the reason is, of course, that these partnerships can do very different things. So a lot of the industry collaborations were done in Europe with IHI. What is very difficult in our setup, but is very, very straightforward in EDCTP3, is to run large clinical studies in Africa, where, of course, you have much more tuberculosis patients. And so maybe, Lara, you want to come in, but I think that project is going exceedingly well.
Yeah, I
Please,
don't know if
please,
you have
please.
time or you want to kind of go to others, but no, indeed, we partnered with IHI we've kind of indeed taken a product, Alphabetica, which is a TB drug, across the continuum through product development. And I think this is a really good example of how the European partnerships can pick up at different points in that value chain, actually, a product and take it along from early stage through to product development and getting it out to the patients that need it the most. So I think this is, and we just have recently an article that was published by IHI on this. So this is probably a very good example of this.
That's a great example. So, do we have a question from the audience? He's still shy. Oh, we do have a question. Please, if you can state your name, organization, and to who is your question, or maybe it's for all of the experts.
I think it's, to be honest, to the panel, so whoever wants to just say. Annika Eberstein from Philips. I do use innovation. There's a lot of potential in the life sciences, especially medical devices. So also in view of the next funding period, where do you see room for synergies and collaboration there with the defense and research and innovation side?
Wow. Who wants to go first?
I can start, and then I'll gladly hand over to the rest of the panel. So if we look forward, I think, one of the things that we do right now, and I'll pick one of our programs as an example, but I think where we're going, and that points to a gap for the future. So we are running a set of projects in an area called Theranostics, which is about sort of combining advanced imaging, advanced diagnostic with the treatment of cancer patients. So you can sort of illuminate the tumor, and then the physician or the doctor can see what's happening during the treatment. So it's both a diagnostic and a therapeutic. Now, the innovation there requires a lot of different stakeholders coming together. You have the technology development, of course, so you need the equivalents of the Philips, the Siemens, the big technology providers, the imaging. You also, of course, need the healthcare system. This is bleeding edge oncology research, and so you need strong cancer centers to be involved. But actually, one of the rate limiting steps is getting the radionuclides into the treatment centers. So you also have to do some supply chain innovation. And so you have to connect that not only with the sort of life science part, but also with innovation in other parts of society for this to work. And I think we are running research projects here, and I think it's starting to come together. The question for the future, and that I think this is where you're going, is then how do you scale this across Europe? What is that sort of innovative mechanism that allow you to take the innovation into large-scale impact? And I think that's really, how do we connect these sort of innovation programs that actually require more than just a lab, where you have to do innovation at the system scale. How do you then scale that up? And I think that's one of the key questions for the future.
Jonathan?
Well, it's interesting that Nicholas mentioned supply chains. And so because in the case of diagnostics for infectious disease, one of the difficulties, particularly if you've got an outbreak, is the transport of the infectious material, where the regulation across Europe is extremely diverse, and it's difficult to get Crimean Congo hemorrhagic fever virus from Spain to Hungary, for example. This is something we had to do recently, and it's just not simple. But this is one of the reasons why we're running exercises at the moment to try and sort out these problems. But there should be mechanisms that allow those to be solved across domains, irrespective of what the particular challenges are. And then if you look at these types of things as well, there's the question when we talk about defense, then there is needs for the military. And as you know, at the moment, there's a slight lowering of the barriers between civil and military. And this is something that's going to need to be done, not only because we've got a war on Europe's borders, but because this is the sensible thing to do when resources are being limited, given the fact that diagnostics for the battlefield could be applied to the clinic and vice versa. We need to work together. And there are very good initiatives at the moment funded by the European Defence Fund, there's Counteract and Resilience, which are bringing together civil and military for diagnostic development in order to benefit both sides.
Lara, Nancy, do you want to add anything? Not really. So let's go on with Nancy. So Nancy, if we look at things from a Flemish perspective, BioVia is often cited as a great example of how research industry and clinical practices can work hand in hand. So tell us your secret. What elements make your ecosystem so dynamic and successful in bridging those words?
Well, let me thank you for acknowledging our successes and indeed bringing together the clinical research, but also the industry and the clinical teams, the healthcare professionals together, because that's what we aim to do. And we are, if I may say, quite successful in doing so. And this is why Flanders is a atypical European country. It's very, very small. It's dense, and it has an ultra-dense network, as you all know. So you will find in our regions top universities, research sites, and institutes, all within a max of, what they say, 90 minutes drive, if no traffic jams. We have an entire value chain on our doorsteps. We have global pharma, medtech, biotech, but we also have specialized vendors, CROs, CDMOs. We have all the specialties needed to create the entire value chain, including logistics, like with our ports and with our very specialized aviation. But we also have access to multi-talented, highly skilled, and polyglot resources. It does help. Then I would like to say that we have pragmatic public instruments that are industry-driven, that are competitive, that are rewarding collaboration and rewarding TRL progression, which is an important aspect to this discussion that we're having today, not just limiting it to research, but bringing products to the market. And then there's the role of BioVia, of course, which I don't know if you're familiar with that, which is a merger of Flanders Bio with BioWin and a couple of other activities. What we try to do is remove all silos and make it one health cluster. So we're unifying medtech, biotech, agtech, health tech, all the techs you can imagine in the healthcare industry together under one roof, speaking with a single voice. What we're trying to do is to be a broker for projects, facilitate and bring together the investors with those that carry projects, and act for the entire industry. And this is what we've been doing in clinical research, yes. This is what we've been doing in Flanders altogether, but I believe that removing those silos is key to success today.
Removing silos, I think Jonathan quite agrees with that.
No, absolutely. Although whenever people talk about silos, I say they're not silos, they're fish bowls that are connected. And you can see what's happening in your neighbor, and you could actually swim through and join them if you wish to. And that's what needs to happen, is that people need to recognize that there are these possibilities for collaborations. Not so long ago, I had a discussion with Yasmine Belkaid, who's the director of the Institut Pasteur, who said that these issues are so important that you can't allow individual egos to limit cooperation. And I think that this is the time when people were building up their empires and competing for what should be public goods has gone, that time must have finished now. And we need to be into a much more collaborative, cooperative, and open research environment.
I see there is a question from the audience, but first I want to hear from Lara. Lara, your work at EDCTP3 focuses on global health partnerships, especially with Africa. How does international cooperation in health and life sciences strengthen Europe's innovation ecosystem overall?
Yeah, I think that's a good segue from your comment, actually. So yeah, I mean, I guess firstly, why international cooperation? And for that, I guess I'll circle back to what I said earlier, which is that life sciences is inherently a global endeavor. And so no single country organization can really take a product right through the entire value chain to advance its development and its manufacturing and distribution. So that's an important point. And as countries in Europe and Africa are striving for having, greater self-reliance, strengthening and diversifying international partnerships across that entire value chain is going to be critical for health sovereignty and security. Because partnerships turn science into solutions, and these are critical for translating excellent science into innovative products and technologies, and that's why Global Health EDCTP3 has partnerships with funders like the Coalition for Epidemic Preparedness Initiatives, CEPI, the Gates Foundation, and with companies like BioNTech, as well as with public health authorities, regional and global initiatives like WHO or WHO Afro and Africa CDC on disease surveillance, capacity development, genomics, product development, so that we pool our resources and expertise across that entire chain. And one tangible example I briefly mentioned is a partnership with industry that was very systematically aiming to develop antimalarials, the antimalarial pipeline, and that is the Coartem Baby, which some of you may have heard recently in the news. This is the first ever malaria therapy to be available for babies weighing less than 5 kilos, and that's a really critical population for which there was no approved medicine or vaccine previously. And that was developed through a Pan-African consortium that was with Novartis and the Medicines for Malaria Vaccine venture, including European and African institutions. And so we also mentioned earlier that we partner with IHI closely on shared priorities like antimicrobial resistance, and this Alpha-Vec TB drug has been one critical outcome of that and received orphan designation from the European Medicines Agency. And then leapfrogging from science to real-world impact also requires partnering beyond research and engaging with the regulatory, procurement and other market-shaping mechanisms. And that's also why we work closely with regional bodies like the European and African medicines agencies and global regulators to try and streamline that process. So then second part of your question was around how that international cooperation strengthens Europe's innovation ecosystem. And I think, partnering with Africa, which is of course our main area, it strengthens health security and prosperity in Europe. Infectious diseases, as I said, know no borders. It's more cost-effective for Europe to tackle infectious diseases through global collaborations. And those global collaborations lead to more effective and widely applicable medical innovations. And they'll also accelerate the delivery of medical innovations to the populations most in need, which in turn expedites disease containment and elimination and protects Europe and the rest of the world. And those international partnerships also allow the sector to move quickly when it matters most. So we've seen, for example, in the crises like COVID-19 or Ebola, or MPOX, that having strong international research networks in place, like the EDCTP Regional Networks of Excellence or Epidemic Preparedness Consortia, that can pivot immediately to respond to these kind of crises, are essential for this responding effectively and protecting and preventing disruptions in global value chains. And a collaboration with Africa is especially valuable, not just because of our geographical proximity or because Africa is tackling exposed and tackling emerging diseases, or indeed, as Nicholas mentioned, non-communicable diseases, this dual burden which Africa faces. But it's also because Africa is a powerhouse of scientific talent and expertise in how to respond to disease outbreaks and control and prevention. And that's thanks in part to investments that EDCTP and others have made, which are long-term, intentional, sustainable investments, as I mentioned earlier. And that fosters equitable long-term partnerships between both continents. And it's not just good for science and innovation, it's also an investment in our security. So finally, I would just say that EU leadership in global health, R&I, is really also a strategic opportunity, but it also requires matched investments, ambitious ones, and enabling policies, flexible collaboration frameworks, and that's all important for ensuring that especially diseases that have high societal impact are addressed appropriately. And with the current reductions in ODA funding and global health R&D funding in general, the EU has an opportunity to step up here and as a credible global leader in life sciences. And I would say now is not the time to scale back or defund global health research partnerships. It's really the time to double down on these investments and to protect us all, especially those in the most vulnerable populations.
Thank you so much, Lara. We have less than 1 minute left, but I want to hear that question. So please, and we will hear, very fast responses.
Of course, I'll keep it brief. Ashley Noriega from the Centre for Future Generations. A question primarily for Jonathan. I was interested in your perspective on medical countermeasures, and I was wondering if you see a role for innovation in biomanufacturing in bringing more of that value chain of MCMs within Europe, where that's beneficial, and are there any specific regulatory innovations that would be needed to make that happen?
If we have 1 minute, I suggest we discuss this over at the lunch break, because that's going to be a long, I can't give a brief answer to that, I'm afraid.
Well, thank you so much for joining us. I want to thank really Jonathan, Lara, Nancy, and Nicholas for being with us for this very fired discussion, very powerful discussion. And I will call now Simon here on stage to present the next panel. Thank you so much.
Thank you. Okay, everybody, thank you so much to our panel. And it's time to move on to our final main topic for today. We've had plenty of references earlier to the importance of AI and data as key drivers of innovation between the life sciences industry and various other parts of the health ecosystem. So the final session of today's event is going to focus on the power of AI and what potential we really need to be focused on capturing in order for Europe's competitiveness, translational medicine, harnessing the excellent resources that we have, including the data, gets channeled into real-world impact. And for that, I'm going to hand over to our executive editor, Florin Zubashku, who's going to guide us through these discussions. Florin, the floor is yours to introduce your panel, and we look forward to following the discussion.
Okay. Thank you very much, Simon. Hello, everyone. My name is Florin Zubashku, executive editor of Science Business. On a normal day, I'd be coordinating our news team, but today I wanted to come here and be part of this conversation on how AI can, what Europe can do to make the best of AI, of upcoming AI technologies, and implement them in our healthcare systems. So, I will start by introducing our panelists. We have 5 experts today. I'll start with Anca Scorzariu. She's Deputy Head of Unit for AI in Health and Life Sciences at DG Connect, the European Commission. Please join me here on stage. Then we have Plamena Markova, who's Chief of International Relations at EMBL. Thank you very much for joining us. Please take a seat. We have Carl Moons, Professor of Clinical Epidemiology at the University Medical Center Utrecht. Martin Vastenburg, Founder and Managing Director at Connected Care, a platform for digital communications in the hospital. And last but not least, we have Robin Lemons, who's Professor and Head of Specialized Program at KU Leuven. Please join us on stage. All right, so let's start with the big picture. Let's set the scene. Let's learn first a bit about what the European Commission has been doing in terms of policy in this field, in this emerging field of AI in health. We're going to go through some of the interesting projects that are happening across Europe in this field, and then we're going to see how, what are the opportunities, but also the bottlenecks in terms of implementing AI in health research and practice. So, Anca, I'm gonna start with you. So, help us set the scene on the latest policy developments and the initiatives your unit is working on.
Thank you, Florin. So, the European Commission wants to make Europe the AI continent, the place to develop trustworthy and advanced AI solutions. And we've set up an action plan on this that builds on 5 pillars: computing power, data, talent, streamlining regulation, and then supporting the deployment and the uptake of solutions in European industries and the public sector. On this last point, just last week, we adopted the Apply AI strategy and the AI in Science strategy. So they're fresh out of the oven, and it's the first time that I get to talk about them in public. So thanks for this opportunity. The Apply AI strategy has a sectoral approach. It's looking at how we can unlock the uptake of AI across critical sectors, healthcare, including pharma being one of them. They're part of 11 sectors, also including energy, defense, robotics, manufacturing, and so on. So we have flagships in each of these sectors, and I'm going to talk more about the ones in healthcare soon. It also includes horizontal measures that span across these sectors. They deal with supporting SMEs, tackling skill gaps and encouraging talent development in AI among healthcare professionals as well as building the ecosystem, having a continuous exchange between industry, regulators, civil society, and so on. Now, the flagships in healthcare include building a network of advanced screening centers to support early detection in cancer and cardiovascular diseases to begin with. So here the idea is that we want to have these centers, at least one in each member state, to act as beacons and to produce evidence and models on how these AI solutions can be deployed and integrated into clinical workflows. Another initiative deals with building a network of excellence in AI deployment to come up with common guidelines and methods that can be shared then among healthcare professionals across the EU to support deployment of solutions in hospitals. We have an initiative on an AI drug discovery challenge for unmet medical needs. And finally, a set of actions on facilitating the process of bringing to the market of medical devices in Europe, so simplifying, clarifying regulation, and so on.
And how do you think these initiatives are going to help roll out more, AI applications for healthcare in Europe?
Well, first of all, we need to have trust in order for these solutions to be taken up. Trust among patients and trust among healthcare providers. And to have trust, you need evidence. You need to show that these solutions work. You need to have clear processes for certification of AI-enabled medical devices. And to build these evidence, we've launched precisely the kind of flagships that I mentioned earlier. In addition, we need to have the building blocks that support innovators in Europe, to help them through building ecosystem, putting them in contact with finally the end users, and making sure that the solutions that are developed meet the expectations and the needs from the end users. So this is why we put a lot of effort into building these ecosystems.
Okay. Thank you very much for this policy introduction. I think there's something wrong with my microphone, or not? Okay. Okay, I'll take this one. Perfect. I want to go through what is actually happening on the field. And here we have both Martin and Robin who can tell us a bit more about actual projects that are trying to implement AI technologies in healthcare. And I'm going to start with Martin. I hope you can give us an introduction to your own project, which is part of a broader cluster of Horizon Europe funded projects focused on this specific challenge.
Yes. I'd love to, thank you. So we're part of a cluster called Stay Healthy, and this cluster aims to use AI to help people stay healthy. So it's not focusing on a specific disease. In general, it's focusing on non-communicable diseases. And it's a cluster of 6 projects in which we're exploring how AI can be used to help children and adolescents, and also their family and the caregivers, make healthy decisions for later on. So this whole cluster is focusing on person-centered and evidence-based disease control, targeting this younger user group. And all of these projects, they all have like the co-creation and development central to make sure that the solutions properly fit the real needs, and the health outcomes are central. I'm here to represent the project Smart Change, and Smart Change is a collaboration of 14 different parties, mostly European, but we also have a Taiwanese partner on board. And in Smart Change, we're aiming to develop a platform that's trustworthy using AI-based decision support, targeting smaller children and adolescents, and making them more aware of how the choices they make early on in life, how they affect the risk later on in life. And I have to say, this really is, it gives friction. Like if you look at the consortium, we have some very strong AI partners, so creating the models, making sure that, for example, the models are explainable and trustworthy, models that can collect data from all different sources, including like sensor data and self-reported data, and then coming up with suggestions on what might be changed in lifestyle. In a project where we are now halfway, well, we conducted a co-creation in 4 different countries, and we have universities involved also in, for example, in lifestyle changes, so a lot of expertise on board. But as soon as you start talking to children about lifestyle changes and risks and future, it's like you're talking to a wall. Like children live in the here and the now, and they're not thinking about how eating unhealthy now might affect the risk of diseases when they're 40 years old. So these projects, I think, have this common theme of how can we bridge this gap between, let's say, all that is possible with AI and all the new insights that we have, but make it resonate with this user group who's not that open to it. So in the case of Smart Change, if I may give a quick example, Like when we're talking to the kids, we're trying to make it smaller and make the families and the children together decide on what they think is important on the short term, and for example, doing healthy activities and setting goals together, rather than thinking about this long-term scope, which is just too far away for these children. And we're now in the stage of preparing the longer-term trials in 4 different countries towards the evidence.
Mm-hmm. Thank you, Martin. Robin, you're also part of, with your project, you're also part of this consortium. So can you tell us a bit about TrustStroke and how do you see the role of AI in clinical research?
Yeah, thank you. So yes, indeed, I'm here on behalf of one of the clinical partners in TruStroke. So here we focus on a specific condition, on stroke, because of the fact that it is such a frequent condition. So more than 1 million people in Europe will suffer a stroke per year, so that's a large number. 1 in 4 adults will suffer a stroke. And it comes with a high mortality, but also morbidity, so it's a major reason for handicap at adult age. So it's a very frequent condition, and it affects many people, but also many people are suffering from this condition even when they survive a stroke. So we think it's necessary to get more insights in specific endpoints and how we can better predict these endpoints, and then of course try to modify the treatment accordingly. So what we're trying to do is we're bringing in different clinical partners, but also data and AI partners. So what we would like to do is to try and predict particular endpoints based on the data that we're collecting. So we think about endpoints like patients are sometimes readmitted in the first month, so it's up to 15%. So what are the reasons for that, and can we potentially prevent this? Recurrence of stroke is of course something that really bothers patients a lot. So they suffer the stroke, but can I then suffer another one? And what can I personally do to prevent this? So can we get more insights? So that also relates to potentially personalized medicine. It's also outcome. Typically, we measure outcome of stroke after 3 months, and it's really focused on the functional outcome. That's what we typically do. That's based on skills that we as physicians have developed. And so, of course, I will come back to that, but we want to predict this outcome better at 3 months. It also, I think, enables patients and relatives more, I think, to get some insights. I mean, the first question that you're asked as a physician is, how will I be? So will this stay? Will the problem that I have, will this go away? Will I be fine in 3 months or not? So can we potentially predict that better? So as mentioned, we're focusing a lot on outcomes as we see them as physicians, but we know we're missing things. And so if you just ask how someone is doing functionally, so for instance, can someone take care of him or herself, walk independently? Those are things that we typically as physicians will ask, but patients suffering from stroke will suffer from many other symptoms like fatigue, anxiety, depression, sleep disturbances. Those are things we typically do not ask in those skills that we use in clinical trials. So therefore, we are collecting all of that information from the patient perspective. That's something else what we're doing here. So we're collecting patient-reported outcome measurements and patient-reported experience measures on that journey, basically, in the first year after the event. I think one of the reasons, of course, is we want to get insights, but we also want to know who is engaged in reporting all these various tools that we want to capture. And so you could potentially think that someone who's really engaged in filling out all kinds of questionnaires, but also other things, monitoring blood pressure, and we can look at that because they're reporting it themselves in the app that we're using. So maybe if someone's really engaged, that could be a predictor maybe of lower recurrence rate. If someone is not engaged, maybe that relates to higher recurrence rate. But if we know these things, we can potentially modify that and earlier intervene to make sure that we identify those patients who are at higher risk for recurrence. So I'm talking about prediction, so that relates immediately, I think, to AI, where we want to develop models that can better predict these events or the different endpoints. So in this project, we're collecting data retrospectively and prospectively, of course. But I want to emphasize here, this is a research project. So we're not implementing this in clinical practice for the moment because we don't know what the performance is of the model. So we don't want to give the information to the physicians at the moment that the patient is admitted. because we're not, of course, we need to be aware about the accuracy first. So we're collecting, we're developing, and of course, we're developing and validating this in a prospective cohort. But at the same time, we're not giving that to the clinicians as of yet, because we want first to establish the robustness of the models that we're designing. And so the other thing I think which is important, of particular in this project, I listened with interest to the previous talk. So collecting data over many European countries is extremely difficult. So, and also the regulation part has been mentioned before, and we can talk about this later, but that relates to regulation difficulties, basically. And so, if you want to capture data from various hospitals in various countries, this will take you a lot of time, and even sometimes this still is not possible. So, if you want to make AI models on a high amount of patient data, the other way to do this is based on federated learning. So that's what we're looking at in this particular project. So collecting data in each hospital, 4 hospitals in the end, and so designing these models to predict the endpoints that I've just discussed, see what the performance is of these models, and based on federated learning, try to build a model that could be relevant for the various hospitals without collecting all the data in one data center. So we don't know yet if the federated model will work, but that's a way basically around collecting lots of data from various hospitals at one particular data center.
Yeah, thank you very much, Robin. I want to come to Plamena now, because EMBL and Google DeepMind have just renewed their partnership and have updated the AlphaFold database. So can you remind us all what that project is and how it's changed the way researchers work in biology?
Sure. And maybe that was a very nice kind of segue from the previous talk, because we are all about collecting big amounts of data, which is different, of course, from the medical data you referred to. EMBL, just maybe to also set the scene, and for those who don't know, is Europe's only intergovernmental life science organization that also performs research and delivers services and runs infrastructure and training. And the EMBL EBI is our UK site, and through that, in fact, EMBL EBI is the world's biggest biodata repository. So really an infrastructure of tremendous proportions and size, where biological data has been collected, annotated, made openly available for many decades. And this was also the reason why Google DeepMind, a few years back, came to us, and we launched a very successful collaboration, which is also an example of a public-private partnership, and there going back to the point of the trust and the ecosystemic approach, but built on trust, allowed us to launch the AlphaFold database, which initially made available state-of-the-art protein structure predictions. It was 1 million initially, now it's 200 million. So really also the size and the speed of uptake is incredible. And of course, this completely revolutionized the way structural biology is done, the way science is done. It completely also democratized the field that traditionally was really very impenetrable, so very difficult to understand, very difficult to come into this field. Now, with really much a click of a button, anyone can really see how their favorite protein structure folds. And this has many consequences. First, of course, changing the way we think about biology, but the way we operate, the way biology then reaches various sectors of sciences and of life. And of course, this partnership is extremely valuable because it allows anyone, industry, academia, medical practitioners, to have access to these proteins and data sets. Now, I'm not sure people know, protein, you hear this a lot, but is it clear what it is? In fact, it's indeed, because otherwise it's a bit difficult to understand the added value. It's a molecular machine in our cells that folds in these beautiful, wonderful 3D structures and of course has incredible impact on the function and underpins also many diseases like Alzheimer's or various cancers and so on. So understanding the structure is understanding the function, which of course then this is relating to drug development, to disease, to health and disease. Eventually, if we push it further enough to application, to prevention and precision medicine. So it's incredibly valuable. And the partnership, of course, we renew it because we see how it really has advanced the field of biology, but also AI. And in this second phase, and indeed this is also fresh from the press because this is a fairly new development for us, we also add a few aspects. So one of them is this component of equitable access. So we want also to roll out programs for training and really make sure that more people have access and understand and can use it. And then to address a bit more this global challenges component. So now we're also open to ISO forms, which means, and we work also with WHO in order to kind of start onboarding viruses and so on. So we really see the potential, and of course, this is one way where the data that has been collected across borders, across years and years of work, and the infrastructure, of course, that underpins it and makes it openly available, is driving life sciences and competitiveness and AI in the field of sciences in an unprecedented way.
Okay, thank you very much, Plavena. Carl, I want to come to you now. So we've heard all these stories about, you know, the potential or the assumed potential of AI in healthcare, and I also want to hear your thoughts on what are the areas where you think that AI could be useful, and where could we use it, and where we should not use it, maybe. Let's frame it that way as well.
No, the latter probably is not the station I think we all passed where we shall not use it. It's all everywhere, AI already, and particularly healthcare maybe is the last sector where it's slowly introducing, for good reasons. Let me first focus on the healthcare, which is not healthcare research, because I think AI can actually change the whole drug development scene and will change the whole drug development scene and make maybe even trials redundant. The previous two topics, I come back on that later, maybe. But first on healthcare. I'm not so sure how it's in other countries, but in our country, there's a huge attention, also the media, on the LLMs. That LLMs are changing the healthcare, particularly making it more efficient, reduce administrative burden, change the speech to text automatically, at a consultation between the doctor and the client, automatically changed by an LLM model into text or to numerical things, to numbers. That's also very helpful. Also, of course, make automatic patient summaries. 40% of the task of clinical professionals is apparently administrative burden. I think also in our hospital, UMC Utrecht. And yes, LLMs are going to change that and make the world more efficient. And all the attention, at least in the Netherlands, is going to there, and also by the media. And I think that's the least important field where AI will have a role in healthcare, because we are using entities or algorithms that are developed for a totally different reason, and we are simply applying ChatGPT and Copilot to do that, and within a few years we do it all, and that's done. But the majority, I think, in our hospital, but I think I traveled the globe a little while with AI already. I think the biggest role is the examples that I just heard, is that we can improve the safety, effectiveness, and particularly the personalization of care. AI, 90% of the AI we're going to use in healthcare is for that, for personalization of care. For example, reading images. AI is never tired. AI is never having an off day. A radiologist can have, with all respect, me too, and then again, go through 100 images at the end of the day when I've seen all my patients. Now, AI never has an off day. So it will read images much quicker. It will reach microscopies much quicker. ECGs, EEGs. In robotics, it's much more efficient. And particularly in the prediction algorithms, predicting the prognosis of patients, predicting the occurrence of diseases for all of us, we are healthy, we think we are. We are not patients yet. In the end, we're all patients, only we don't know yet. But predicting what disease we're going to develop with AI, that's the future, making it much more personal.
Okay. And what do you think are the main bottlenecks to achieving that?
Yeah, that's a good point.
We mentioned trust before and patience.
Yeah.
How easy is it going to be to, or how hard is it going to be to convince
Yeah,
patients
the interesting
that this
thing
stuff
is the European system. AI is, when it's becoming a medical device, when AI is going into a software, then it's suddenly, and we're going to use it for health applications, we call it a medical device. And then we suddenly have the MDR, IVDR regulation in the EU, with the notified bodies in between. And if you think about medical drugs, that's a totally different system. I don't say that you can compare AI to drugs, never do that, because you don't need trials for AI in a majority. I hear the word clinical trial a lot. I assume we mean the word randomized trials, which is different than a clinical trial, but I think we mean randomized trials. And if you look at drugs, they have, preclinical, phase 1, phase 2, phase 3, comparative effectiveness, a pharmacoeconomic analysis, a PMS, post-marketing. You need to have done everything, and then you go to the EMA or the FDA with this huge file under your arm, and then they have all the data that they need, including safety, pharmacokinetics, they have it, and they make a decision, yes or no, on the market. But the MDR and the IVDR is a CE system. And AI is in therapeutics and robots, or in insulin pumps or pacemaker, but the majority of AI is simply information providing. It's simply showing a prediction. It doesn't do anything with the patient. We need to act upon that. We as doctors or the clients or the individuals. And for CE, you don't need to show and to prove that much that you would like to know before you let it loose on your patient and clients. What I mean, the evidence and data that we need to show to get CE on AI is not enough to make the decision to let it loose on our clients and our patients and our citizens in Europe. So I think there's a huge gap between CE marking, because CE marking means you're on the market, but that doesn't mean you have economic profit. So if I want to give one recommendation to the European Committee, is make sure that the biggest value of death is not CE. The biggest value of death is after CE. And there I think we need guidance, and randomized trials are not the solution. We need fit-for-purpose data and evidence generation, given the type of AI.
Right.
And that's maybe a game changer.
I want to turn to the rest of the panel, especially Martin and Robin, but also Plamena. Have you thought about, trustworthy ways of testing and vetting these technologies before market rollout? Yeah.
Well, if I may add, so I totally recognize what you sketch here, and that's something interesting happening here, because the development of AI is going very quickly, and everybody notices now in the past years things are changing rapidly. And from a company perspective, getting through this certification, it's a process that takes at least 2 years, but within the 2 years, you're 3 steps further with your product. So there's some imbalance there, like the innovation is much faster than the certification, making it impossible for a company to properly bring things to the market. And I think if we compare, for example, to the US, where they have more like an open approach, I think the European way of doing has its merits, like we have much more trustworthy and a humanized approach to the innovation, but it's also slowing down. And maybe it's good to link here, like from the company perspective, I think that there's multiple things which are blocking this step to market. And on the one hand, it's the EU, it's not a single market, so if we're targeting all the different countries, we have to address to different regulatory processes, we have different reimbursement methods, we have no clear road to market. The data governance is different in each of the countries. And the strength of the EU basically now slows down the innovation. And it would really help if we could get to a setting where we have like a shared EU evaluation framework which is much more focusing also on iterative innovation, so you can much easier adopt it, the small changes that you make, get them certified and bring things to market iteratively, and have more like an outcome-based procurement way of reimbursement, triggering the companies to focus on outcome rather than the current setting.
Right. I don't know, Robin, if you want to add something to that. Then I'll come to you, Anka, to hear the Commission perspective on this issue.
Well, I think there's two things. I think there's research and there's clinical implementation. And so the problem with the MDR is that it is slowing down innovation. And the reason for that is because if you do a research project, so people from MDR and regulatory perspective would always say you have to make sure that they're part of your project from the start. But if you do that with every research question that you start, it will slow things down. A lot of things we do in research will just not make it to the end. And that's not that's not really a problem. That's how research works, right? And you have to let development and research go along. And sometimes this will make it to the market, of course, that's the aim, but it's not that 100% of what we do will make it to the market. And so that's a little bit a problem with the different European countries, and so we have experienced this. So we put in this protocol, we're going to develop models in a retrospective cohort, then of course, then thereafter we want to see whether in the prospective cohort, how it performs, maybe have to develop new models. This is all research for us. But the moment that you put validate in a prospective study into your protocol, then the alarm bells go off. Not in every country, funnily. So some countries will say, well, this is research indeed. So MDR does not apply. And so approval from the ethics and everything has gone smoothly, relatively. But other countries will say, well, no, whatever you're going to do, MDR applies. So you have to follow a completely different pathway, which takes a lot more time. And so one of the reasons is that they say, well, but if your product, which is an AI-related product, of course, shows that it's very accurate and robust, then you have to go back and do all the MDR steps again. I think that from a research perspective, that is not such a burden in relation to if MDR would apply to everything what we start in research will slow down innovation. So I agree that if you have a robust model and you have to go back, it will take more time. But I think the steps before, and many people are doing research, that will go much faster. Mm-hmm. So we need to be a little bit, there needs to be a strategy here also in Europe that we look at it the same way, and that we use regulation not to slow down innovation, but to make sure that we facilitate innovation and bring things to the market.
Plamène, I don't know if you wanted to add a few thoughts on this.
I mean, my perspective is a bit different because in a way, EMBO is an intergovernmental organization, so it has a different legal framework that allows us to be a bit more agile or faster in certain things. We, of course, our core business is fundamental research. However, we also have a very strong service provision component and innovation, and we do engage very strongly in that. And I share some of the views that already have been shared. But most importantly, I mean, and this has to be stressed, it's really good to have an overview of everything that is available, but keeping in mind that not all research will eventually end up at that level is important, and how you decide to fund or to support different types of research for its purposes is also, I think, one very strong question right now on the EU level in the different countries, and one has to be conscious that, you know, sometimes pushing innovation or pushing commercialization where it doesn't make sense, it's to no one's benefit, right? Mm-hmm. I mean, sometimes the research takes many, many years to reach that stage, and this has to be recognized also in the type of support and investment.
Okay. Anka, I want to come to you. Do you have any reaction to this? What are your thoughts on this issue of speeding up a bit regulations? And whether these new strategies will facilitate that, that faster rollout of these technologies.
So we recognize that it does take a long time for a medical device to be certified. The healthcare field is one of the most highly regulated fields of the industry for good reason. Yes. And despite this long process of certification, we also know that the AI-enabled medical devices available, certified in Europe, has also exploded. Just in the radiology field, in 2016, there were 6 CE-certified products on the market. Today, there are more than 270. There is a lot of research going into AI in health, 533 projects funded by the EU from Horizon 2020 and Horizon Europe over the last 10 years, more than 3.5 billion invested into research. But then this translates quite well to innovation. We've also taken note that the number of annually published patents in the EU has increased 20-fold compared to what we had a decade ago. But then there's a big gap between innovation and uptake. So between having all of these products that deliver great results and having them used in clinical practice, huge gap. So now with the Apply AI strategy and with the AI in Science strategy, we're trying to fill this gap. And my co-speakers have addressed some of the challenges, the trust, the framework for actually testing in safe conditions, in real-life settings. So there is a testing and experimentation facility in health that's helping innovators do just that, regulatory sandboxes, creating these networks of, these communities of practice where solutions are deployed and tested in hospitals, in safe environments, and evidence is produced and then shared, and this can stimulate adoption in other places and slowly turning these from pilots to actual adoption at scale. And here, of course, the member states play a very important role because healthcare is a national competence and we need member states to have national strategies for AI in health. We now know that 19 EU member states have strategies for AI that mention healthcare as an important sector. Not all of them have measures how to transform this vision into reality and how to support uptake. We will see how we can incentivize this under the next multi-annual framework program with the national and regional partnership programs and the competitiveness fund, Horizon Europe, how to bring all of these plans together so we work collaboratively. It's not possible for the Commission alone to break this, to bridge this gap in uptake.
Yeah, I'm very convinced that rollout and adoption will be different across different geographies in Europe. In fact, not very long ago, I went to X-ray my wrist in Romania and I received the image on a CD. So I think they're pretty far away from the AI stuff. You wanted to come in.
Yeah, a little. I'm not so sure whether the MDR and IVDR slows down medical technology. I think actually it's a huge opportunity. How long does it take a drug to get to the market? 10, 15 years? The big difference is then when it gets to the market, everything is known and everything is set in stone what we need to show at the FDA, at the EMA. The big difference is, and I think there we could make a change, is that I read the whole MDR letter for letter. I would not recommend anyone else to do it, by the way, but I did once. And I think we can very much learn if we are a little bit more in specifying, which is specified for medical drugs. Everyone knows from the start what they need to do the coming 10, 15 years, clearly. Set in stone across the globe. But what is not, it is for AI or medical technology, because the data and evidence that is needed for AI that supports a pacemaker, which goes into our body for 30 years, is totally different, I hope, that we like to see, than a little app AI for step counting. You need other data and evidence and other studies. So if we can help the world a little bit better, is that we give a little bit more focus and attention to what data and evidence do we desire, not require, but desire to get to CE. And then I go one step further, because the second value of that is the biggest, the adoption, but that's beyond CE. A little bit more connection between what is needed for CE, tailored to the specific types of AI or medical technology, and then also what is needed for adoption, reimbursement, and that's a second one. But I think we would definitely help all these innovators also in the room. That's my takeaway.
Yeah, and of course the AI Act will help on that. It's filling that gap, and it's complementary to the MDR, IVDR regulations, and it has this risk-based approach, where if you are producing an AI solution that is not to be deployed in a high-risk setting, for example, I don't know, border control or a medical device, it has far fewer boxes to tick before it can be deployed on the market.
But it's only focused on risk, and we don't know, it's not focused on effectiveness, on cost effectiveness, unfortunately. It's too much focused on risk. I also read the AI Act, also not easy to read, but...
Yes, voilà. So, but they're complementary, because...
Yeah, they're complementary, definitely, yeah.
And there's the health assessment, health technology assessment rules that then also look at effectiveness and comparing one solution against others, and that's linked to reimbursement. So there is actually a whole network of regulations that are meant to work together to support the deployment of AI solutions in healthcare.
Right. Before I move to my next question, I want to check in with the audience and see whether anyone has any questions so far. Yes, a couple of questions already. Perfect. Good. So let's start here in front. Please introduce yourself. You'll get a microphone now. Thank you.
Thank you. This is a very interesting discussion. One thing that we have discussed in where I am is whether this is a change from traditional clinical or innovation research, because we will have to work very close with the industry, because they have all the big language models, etc., that we need. So that's something I'd like you to comment on. I mean, it risks opportunities, kind of, because we have very straight lines between pharma industry and academia and healthcare. So how do we deal with that with relation to the big tech providers? And the other issue that we have been discussing is whether or not the AI Act, should there be different rules for the commercially produced AI development or the academic? If you have any thoughts on that, that would be interesting.
Okay, so two questions. Who wants to take the first one on the relation between research and big tech?
Yeah, the first was particularly...
And then Plamena, please.
Yeah, I was looking at you.
Oh,
I think it's linking to you.
I thought your first question was also about the LLMs that comes from big tech, like ChatGPT, Copilot. Yeah, the good news is there's not such a problem. It's already out there. I mean, if I use ChatGPT in Dutch, I will also get it back in Dutch. Increasingly, it's adapting already to all national languages. And I think it's just a matter of very, very short time that it's applicable to every language in Europe. Let's start there. And if it's applicable to the world, then it will, in very short time, also applicable to the different healthcare applications. It's not a medical device. It's simply an assisting tool that we apply.
But it's a tool where you data ownership and all that.
That's something else. Yeah. Yeah, that's a good point. Yeah, that's a good point. The question, by the way, is how do we deal with the fact that we give in data to ChatGPT, and that data is then suddenly somewhere in the cloud that everyone can use. So be careful what you put in your prompt. But that's something else. Now, at least what I know from the Netherlands, but I also know in other countries that there are clear cloud solutions being developed where for medical reasons that we use the LLMs, that it remains only in your own accessible cloud, and your own is in this case the institute. So that I think it's a matter of time to close the access from outsiders to the information of patients in this case that you provide to the LLM. I think that's a key. Good point. I didn't address that at all. Yeah.
Okay, I don't know, Plamena, did you want to comment on this issue?
I suspect that my answer would not be as good news as Caro delivered, but then because perhaps it's much more kind of course, in the medical context. But on this front of collaborating or bringing the different sectors together, maybe indeed the good news for us is that we at EMBL, we run this partnership, or we're part of it. It's called Open Targets, where we work with big pharma for many years now for drug validation and so on. And they come in, and again, I think this is in an ecosystem built on trust and somehow on this iterative collaboration and openness, where it's a drug validation platform, and then in a way, everything is, of course, then made openly accessible. And this is something that we have agreed with pharma. They're willing, they're engaging. So it's really a mutual benefit. So perhaps just to say it works. And this is, we also think this is the future going forward. And this is also the case with DeepMind, right? I mean, one of the conditions that was posed when we were discussing the AlphaFold collaboration is that the data will be made available. This is our model. This is why we were created. This is what we want to see. Same with pharma, same with other sectors. So hopefully the good news here is that there are already certain platforms, certain models that work, and going forward, I think they just have to be taken as good examples also when we venture into the AI innovation.
Okay, there was one more question in the back, please. Yes. Yeah, introduce yourself, please.
Annika Eberstein from Philips again. I have a question to the innovators on the panel about regulatory sandboxes, because that's now one of the solutions put forward. And at least in the industry, there's a lot of concerns that these may become just glorified help desks. So I'm asking to you, like, what kind of features would you like to see to actually, push the boundaries of regulatory science in the work that you do to make sandboxes successful?
Martin, Robin, do you have any thoughts on that?
I think what would really benefit from the start, I think, to have a sort of a European approach to this, because every country that goes, so the larger the projects we do, the more countries we have, and the regulatory issues that we have are different. And I sometimes I really don't understand why. And I think one of the things that we can do better is to communicate better. I think as clinicians, we need to talk to regulatory bodies, but we also need to talk to our regulatory institutes within our institutions so that they understand better what we need. And so that so what the questions are that we are looking at in particular projects, and then how does the regulatory apply to that? I think what we notice a lot if we look at the legal departments in our institutions, they really want to be restrictive because they fear that if something goes wrong, there will be a lawsuit. And so they're very restrictive, but they sometimes then forget what the real questions are that we're asking in a project. And I think communicating better helps to have them understand. So just as an example, we explain to them, so when you say prospective and validate in one word, so everything changes all of a sudden. And so, but if you state now that validation means that you want to validate models, but you want to do this in a prospective cohort, but you want to retrospectively do that, of course, because that's what you're doing if you validate something. If you explain it, then all of a sudden everything changes and say, oh, now we do understand. But just rephrase it slightly and we'll make it easier for you that we can go with the protocol that you have and you follow the right pathway. So that really helps, I think. But what I find striking is that although we have European regulations for various things, of course, there are also national laws, but sometimes even without national laws, the interpretation of the European regulations is different from country to country. And that is something I really do not understand. And the reason typically that's giving is that we cannot judge something now differently than we did 3 years ago in another project because we need to be consistent. I don't think we need to be consistent, we need to be correct. And that is something we can do better in Europe, I think, to facilitate.
Yeah, Martin, what are your thoughts on the question related to regulatory sandboxes?
Yeah, I'm not sure if I'm able to answer the question, but I would like to link to Robert, and maybe that hooks the question. So, as an innovator, so I'm linked to university, but also the company, and from the company perspective, the biggest challenge we face is that the development is just much faster than the regulatory aspects, and well, that's where the tension is. So asking like, how can we facilitate that better? Is giving more like a playground where we can also open up for these explorations before getting into all these. As soon as we get in the setting of being risk adverse, where we get, if we get to the medical device regulations, then we're blocking the innovation.
Yeah. I have.
And I just want to add one
more
thing. So what we're also trying to do now in new projects that we're submitting is to not just focus on clinical partners, data experts, and AI, but also having law departments as part of the project, because I think they need to be part of this from the start. Because I'm just an ignorant clinician, so I don't know many of these things, of course. So it really helps to have them on board from the start and to guide a little bit what we're doing. And so that's what we're focusing on now.
Okay.
If I may add, so we do have them in the project from the start, and it helps a lot, and at the same time, it doesn't make things easier.
No, that's also.
Okay. Well, we're very close to the end, but I want to ask a broader question. I mean, obviously, we've been discussing about the potential of AI in healthcare and medical research, but how do we measure the success? Is it patient outcomes? Is it reducing risk? Is it offering faster access? Speeding up research? So how are we going to measure the success of all this stuff that seems to be rolled out at a very fast pace at the moment? So I don't know, Martin, maybe you want to say a few words about that.
Yeah, I would mostly frame this as like value for stakeholders, and obviously that's a more abstract way of looking at it. And I have to say, if I look at many of the AI projects now, they seem to be still at the level of like creating something, focusing on like data scientists. Really, like many products are still on an AI level, like showing all the data, but only the real experts can understand what's happening there. And obviously, when we want to get to impact, we need to make sure that we get the impact for the healthcare professionals and for the patients. And make sure as many people as possible get a better, well, in the end, quality of life, I would say. As a side note, I would like to mention, like, I think the key strength of the EU here is that we're not aiming to get like the biggest models or the highest collaborations there, but we have to get to the most usable, most trustworthy, the most human-centered. And then I agree, like the most personalized solutions, and that's where the opportunity is for us here as a continent.
Okay, good. Who wants to comment next on measuring success in it? Yes.
So my colleague mentioned that randomized controlled trials does not relate, but it does, I think, and it relates to the fact that randomized controlled trials can help with the perception in the public, basically. Can we use this in the clinical practice? And so there are trials now being done on large scales all over the world in cluster-based randomization in hospitals, where implementation of AI and so at different moments, because that's the cluster-based design. And so looking at, for instance, recurrence rate of stroke. And so to see whether indeed, if the hospitals has used the AI models, whether indeed the recurrence rates are lower, what you would expect. And so some of these trials do show that, others do not. So that helps a little bit, I think, with the perception that we can use this. Of course, we need to focus on measuring endpoints, and they should be, as we all know now, for clinical trials based on patient-oriented. But also we need to know how patients the experience of the fact that AI is part of their decision process, how they perceive that. We should be measuring that as well, I think. And of course, if we want to use the data that patients are collecting themselves via apps, whether we use them or not, and how would that be of benefit is also something we can measure. And just a small thing, I think we all think that AI is already there and we can use it. I think for a lot of things, we're not really sure. There's a very nice study in a particular country in different hospitals where they used AI for imaging analysis. And so in all the models, AI was very good. And so, but what happened in the hospitals where AI was used, that physicians were becoming sloppy because they thought, we have the AI model, we don't have to look at anything anymore. And so the rate of discovery was lower in the hospitals that used AI, which does not mean that AI is not of benefit. But we as physicians and medical professionals in general need to understand how we can use it and implement it. Mm-hmm. So that's also something we need, and that's also what we're thinking about of a new project, how we're going to implement Gen AI in clinical practice. Is our medical professionals using it? Do they know how to use it? That is something that's also something that relates to adoption, I think, but that is something we need to look at. And so again, this is not saying that we should not use it. I think we should, because it gives us a lot of benefit, but we also need to understand how to do this.
Okay. Plamena, what's the measure of success in using AI for biology research?
I think I would need to go on a retreat to think about that a little bit to be able to answer this question. But to me, obviously, at the end of all of this is well-being, right? Societal, planetary well-being is what we're talking about, and seeing how we can improve this with all these new tools that are available to us. For me, however, if the question is in the context of boosting competitiveness in Europe, let's say what's a success, one of the key and also coming from a research infrastructure world, right? I mean, these are the different perspectives. To me, Europe has an incredible advantage here. So it's not for no reason that one of the biggest US companies came to Europe to collaborate. It's because Europe is good, it has the right data infrastructures, it's been created for many years, and also because there's no equivalent in a way. People wonder why, because there is no equivalent. Otherwise, probably they would have gone to China or to the US. They came to Europe to collaborate here. And so we have an incredible potential, incredible assets. To me, if we're successful, we should be able to capitalize on those assets while we're also looking to the new future that AI is offering. If we don't have resilient, open, accessible data infrastructures that are not dependent on the oscillations or the fragmentation that is brought by geopolitical developments, and we live it now, we won't be able to capitalize on any new feature, because this will be like building ships when your sea has dried out.
Yeah.
Mm-hmm. It would not work, so we would not really be able to do any successful uptake.
Yeah.
So making sure that the investment that is there is really being rationalized, supported meaningfully, in order to underpin these new developments. And that is not just the infrastructure, this is the fundamental research that underpins all this is the talent, which we know we're lacking. We're lacking the talent. We have the AI, it's very fast. We don't have the trained people to do this. This is one of the biggest challenges. So success would be also to see that we do have these people who can also bridge research and medical sectors successfully, meaningfully.
Okay. Anka, I want to end with a question for you on how do you think all of this will be reflected in upcoming priorities for research innovation policy in the EU?
So we're very much aligned, really, with where the priorities are, driving personalized medicine, investing in AI for prevention, for early detection and screening, the importance of having the right data infrastructure, data that is accessible for training AI models, but also high quality. Because, for example, the European Health Data Space is working on ensuring that the data is accessible for secondary use, for research and innovation. But when it comes to having it high quality, standardized, with the right metadata, harmonized and all of that. There aren't really provisions on that in the regulation. However, we have digital infrastructures like that federate data. Robin mentioned this being done in his project, but we have, for example, Cancer Image Europe, which has a consortium of 95 entities, both data holders, hospitals, and data users, innovators who want to use this data to develop models. And this kind of links to the question on collaboration between hospitals, healthcare providers, and industry. That's one example. Another one is the Virtual Human Twins initiative, where more than 100 industry, academia, innovators signed the manifesto to collaborate together to develop common models. We will soon start working on an advanced platform that would enable this collaboration. And this is another area for the future, virtual human twins. It holds huge potential for accelerating discoveries and accelerating innovation. And of course, supercomputing is an important resource, and we've invested a lot in setting up AI factories that would support the training of models and making these factories available to SMEs, making them available to researchers. We have 19 AI factories that will come online as of next year, and more than 15 of them have identified healthcare and life sciences and biotech as priority areas. So voilà. A lot of work on many parallel tracks.
Indeed, yeah. It seems to me that we have a lot of work ahead of us, but I think it's time to end. Thank you very much to the five of you. I've really enjoyed this conversation, so thank you very much for coming. And thank you to the audience here and to the people who are watching us online. Thanks very much for being patient with us this morning. Now, please give our panelists a round of applause. Then I'll invite Simon to say a few words at the end. Thank you.
So thank you to this panel and to all of the other speakers who've contributed so richly to today's discussions. It just remains for me to say a few words of thanks, first of all to all of those of you who took the time to be with us today, both here in Brussels and those of you who've been joining online. Also to thank our two sponsors, Novartis and Smart Change, for their very active involvement in helping us put together today's event. And of course to the Science Business team behind the scenes who make all of this work as smoothly as it does. So looking ahead, first of all, you'll be able to read some more editorial coverage of today's discussions courtesy of Florin and the news team. So please keep a close eye on sciencebusiness.net and our various news services in the next few days if you want to have a written memory of today's discussions. We will be carrying these and more forward at the beginning of February 4th and 5th to be precise, at our next annual network conference, which we are slightly provocatively calling Moment of Truth. Can Europe empower research and innovation to redefine its future? So we're going to be taking these discussions and putting them into the bigger picture context of the political negotiations around the MFF, Competitiveness Fund, FP10 and more. So you are warmly invited to come and join us in early February, which will be here in Brussels at Maison de la Poste. And last but not least, for those of you who have the time, a network lunch awaits. So please feel free to carry on the conversations over a bite to eat and something to drink. And thank you again for being with us today. We look forward to seeing you soon.